Lovely good afternoon, my dear friends. I hope you all are keeping yourself safe and sound, and welcome to this surgery session live, wherein we are talking about the trauma situation. I'm just waiting for a few moments so that you are able to access this, and let the message be shared in the group. Right, my dear lovely friends. I hope I'm audible, visible, everything is fine. So, in today's session, beta, let us quickly rewind our previous journey. Right, beta. So, in the last class, let us quickly revise what we actually talked about. We were trying to understand that how the most important thing for a doctor, that is to save the life, how you are going to do this in your practice. Whenever any trauma patient comes to us, any patient who comes to us in emergency, we know that we are carrying a big responsibility on our shoulders. That is, we have to save the life. Beta, you are called the second God. Aap dusre Bhagwan hai, right? So most important for us is to save the life, and how simply we try to understand that what is the most important thing for life? It is oxygen. How you are having oxygen in your different cells inside the body. If you just try to look at yourself, see this wonderful creation of God. You take this air inside, either from the nose or from the mouth. This air goes through your airways, then it goes into your lungs, and then from the lungs it is going into the blood, and blood is that pipeline which is distributing this oxygen to every cell of the body. As a doctor, whenever we come across any patient wherein we suspect that probably oxygen is not able to reach to different cells of the body, you have to ensure the proper delivery of oxygen. For this, we do a primary assessment wherein we talk about A, B, C, D, E. A for yes, very good. You have to speak out, beta. A for, B for, C for, D for, E for. Wonderful. So airway breathing, circulation, disability, and exposure. We have to ensure the oxygen delivery through this airway. If the patient is not able to take the oxygen through this, then you have to put something, maybe a laryngeal mask airway, or maybe endotracheal tube, or maybe you can do a tracheostomy or cricothyroidotomy or a needle cricothyroidotomy so that you can deliver the oxygen into the airways. Once the oxygen goes towards the lungs, then you have to see whether the patient's lungs are able to expand or not. Because if the lung is not able to expand, beta, how will the oxygen reach into the alveoli and how it will go into the blood? So in trauma situations, if you find that there is some collection in the pleural cavity because of which the lung is getting collapsed, you have to drain that collection. You have to expand the lungs. Once the lungs are expanded, then you have to see the pipeline from where the oxygen is going to the different cells of the body, whether there is any leak in that pipeline or not. Even if there is a leak, we do understand that as soon as the patient has come to us, the patient would be losing in intravascular volume. Patient would be losing in the pressure. And if the pressure is going down, then definitely how will the oxygen be supplied to different cells of the body? So we have to restore that intravascular volume. We have to restore that intravascular pressure by pumping in IV fluids. We can put 2 wide bore IV cannulas. You know the color scheme, beta. Can you quickly revise that color scheme of the cannulas? Orange, gray, green, pink, blue, yellow, and violet. Wonderful. Very good. Can you repeat this once again, beta? The color scheme of the cannulas? Orange. Perfect. So we use the wide bore IV cannulas, like the orange is 14 gauge, gray is 16 gauge. When we have to pump in more amount of fluid in a short period of time, obviously we have to use a wide bore cannula. We are pumping in crystalloids, usually the normal saline. 1 liter of normal saline pumped within 1 hour. We don't use colloids, beta, because colloids have got proteins. And if we are giving proteins in this particular situation, when the pipeline is leaking out, then this colloid will also be leaking out, proteins will be leaking out, and proteins will exert osmotic pressure, will drag fluid from the intravascular into the extravascular compartment. So it will further aggravate hypovolemia. That is why we avoid using colloids till the time the pipeline is leaking. When you are pumping in IV fluids to restore the pressure, wonderful. But if suppose patient has lost significant amount of blood, say more than 30% of blood loss has occurred, then maybe inside his blood sufficient RBCs are not there, sufficient hemoglobin is not there. So whatever oxygen the patient is taking inside, if we have to facilitate that oxygen to reach to different cells of the body, it becomes your duty, beta G, as a doctor, to give that RBC and hemoglobin also, so that this hemoglobin can carry the oxygen to different cells of the body. So more than 30% of blood loss, you have to give blood transfusions, you have to give packed red cells. Also, my dear doctors, if we want that the pipeline which is leaking has to be sealed, the best method to control bleeding is a direct pressure. But if suppose the bleeding is internal, where you cannot apply direct pressure from outside, then you try giving platelets and fresh frozen plasma, which is rich in clotting factors, so that these platelets and clotting factors can stop the bleed. We can also use epsilon aminocaproic acid, that is tranexamic acid, to stop this bleed, and the first dose should be given within 10 minutes or preferably within 3 hours. The second dose to be repeated within 8 hours. By doing this, we are also trying to control the leak in the pipeline. But many a times, even after pumping in IV fluids, blood, tranexamic acid, the platelets, the clotting factors, fresh frozen plasma, the pipeline is not closing. The leak in the pipeline is not closing. So we might have to apply direct pressure, and for that we have to open or explore that particular area, go inside, apply the direct pressure, and that is how we can stop the bleed. That is how you'll be able to save the life of your patient. Whatever fluid we are giving in, whether that is adequate or not, can be assessed by urine output. And minimum urine output in an adult is more than 0.5 ml per kg per hour. In children, 1, infants, it is 2 ml per kg per hour. Once this basic resuscitation is done, we can quickly calculate that what would be the disability in this patient. Please do remember, beta, for this we use Glasgow Coma Scale, and Glasgow Coma Scale is not something which is used only in head injury, but it is used in any trauma patient, any bleeding patient, so that even if it is a case of liver injury or femur fracture, if the blood is getting lost, that means the oxygen supply to the brain is not proper. So the patient may present with loss of consciousness, may have deteriorating eye responses, verbal responses, and motor responses. So you as a doctor have to quickly check these eye, verbal, and motor responses. We know, just a quick revision, beta, I4 is spontaneous opening of eyes, I3 to voice or sound, I2 pressure pain, I1 no response, verbal 5 conscious and oriented, 4 confused, 3 inappropriate words, 2 incomprehensible sounds, 1 none. Motor 6 obeys, 5 localize, 4 normal flexion or withdraws, 3 abnormal flexion, 2 extension, and 1 none. Mild, moderate, and severe. We know that total maximum GCS is 15, total minimum is 3. 13 to 15 is mild, 9 to 12 is moderate, 8 or less than 8 is severe. So this time we had a question 10 GCS, that is moderate. If there is any variable response, best response is considered. If you cannot calculate any response, use the term NT, that is non-testable. Motor score is good for prognosis. Apart from this, exposure. While undressing the patient, we have to take care of hypothermia. Patient should not go into hypothermia, because already if bleeding is taking place, it is not only the blood which is getting lost, but also heat is getting lost from inside the body. Patient is going into hypothermia. So never ever expose the patient to air conditioned environment just like that without any proper warm blankets or something. Whatever fluids you are giving in this patient, they should not be cold fluids, beta, they should be warm fluids. Once you are able to save the life of the patient, you can quickly do a triage there, where you can classify them into red, yellow, green, black categories. Red, patient which require immediate intervention within 6 hours, usually within 1 hour. And yellow is something which is where the patient requires early intervention within 6 to 24 hours. Green is an ambulatory walking patient who may require some hospital care. Black is black is pulseless. Patient has either died or the situation is such that whatever you do, you will not be able to save the life of your patient. And white is something who is an ambulatory patient who does not even require hospital care. Once this basic story is done, the patient is saved, segregation has been done. Now you can do a secondary survey. Secondary survey would be a detailed survey where you take a detailed history, do a head to toe detailed clinical examination, do specific investigations and definitive treatment. When you're taking the history, beta, please do not forget to ask about those 5 points. What are those 5 points, beta G? Ample. A for allergies, M for medication, P for past illness, pregnancy, L for last meal, E for events of injury, right? So we have to take all this into consideration, and then we go with the specific treatment for that particular injury. If we talk about the different type of injuries in the body, going in a sequence from head, face, neck, chest, abdomen. In the head, we know there are three things: scalp, bone, brain. In the scalp, loose irregular tissue is the most dangerous zone for infections because there are emissary veins which can travel from the scalp into the brain. So even if a patient has suffered from scalp injury, the roadside dirt can travel into the emissary veins and can go into the brain and can cause severe brain infections. As a doctor, we cannot take these scalp wounds lightly. We have to clean these wounds nicely. We have to irrigate them nicely with normal saline. And then we have to suture these wounds in two layers. First, the galea, and second, the skin. Then we come to the bone. In the bone, we can understand better that we talk about different fractures. Linear fracture due to blunt trauma, depressed fracture due to penetrating trauma, base of skull fracture which can be divided into anterior, middle and posterior cranial fossa. Anterior cranial fossa, it is a cribriform plate which gets injured, because of which the CSF from the brain can come out through the nose, CSF rhinorrhea, and we can find periorbital hematomas, raccoon eyes or panda's sign. Middle cranial fossa fractures, the Peters part of temporal bone, CSF coming out from the ear, CSF autoria, Bettel sign, bruising, brownish discoloration around the mastoid. Posterior cranial fossa, it is the occipital region which gets injured, and we can find a bruising in the occipital region. Then we go inside the brain. In the brain, there can be primary or secondary injuries. Primary is a direct injury to the brain parenchyma, and secondary is the after effect of this primary injury. Primary injuries can be classified into axonal, concussion and laceration. Axonal injury can have a variable presentation depending on the number of axons injured, the severity of axons injured. If only very little axons are injured, then patient may be normal. More axons injured, patient may be confused. More axons injured, patient may be in coma. And huge amount of axons injured, patient may even die. We do not find significant thing on CT scan. It is normal in 80% of the cases. 20% we can find some punctate hemorrhages in diffuse axonal injury. Concussion is just like a hidden injury wherein the patient presents with headache, nausea and amnesia. CT scan would be normal. We cannot ignore these patients. We advise them rest and hydration. Laceration is something which is avulsion of the brain parenchyma, so there will be neurological deficit which usually persists for more than 24 hours. Then, because of this head injury, there might be some tearing of the blood vessels here and there, because of which blood may get collected here and there inside the brain. Beta G, if it gets collected outside the dura mater, we call it as extradural or epidural. If it gets collected beneath the dura mater, it is subdural. If it gets collected in the arachnoid space, that is subarachnoid. If it gets collected within the brain parenchyma, that is intracerebral. And many times when these hematomas are developing inside the brain, pressure inside the cranium is increasing, that is intracranial pressure is increasing, which can force the brain to herniate out through the foramen magnum. So even cerebral herniation is a type of secondary brain injury. Extradural hematoma, most commonly seen in the temporoparietal region due to injury to middle meningeal artery, which is a branch of maxillary artery. It can even be due to injury to transverse sagittal sinuses. Many times we see that since extradural is far away from the brain parenchyma, this hematoma, as it is developing and enlarging, it is taking time to put pressure on the underlying brain parenchyma. This time, when the brain parenchyma is not compressed, the patient remains normal and can carry out the normal routine activities, and this is what we call as lucid interval, right? When we do a CT scan, we find a hyperdense biconvex shadow in extradural hematomas. Subdural hematoma is collection beneath the dura mater. Most often, this is due to tearing of the cortical bridging veins. This subdural hematoma is also called as Boxer's hematoma. We can classify the subdural into acute, subacute, and chronic. 0 to 3 days is acute, 4 to 21 days is subacute, and more than 21 days is chronic. When we do a CT scan in these patients, we find a hyperdense, convexo-concave, crescent type of hematomas. And we understood the concept nicely that why extradural appears biconvex, that is because of the attachment of dura mater to the bone at different places inside. Why subdural appears concavo-convex or convexo-concave or a crescent type, again the same reason. In the management of head injuries, in the management of different hematomas inside, what we want is, we want that brain cells should receive oxygen as early as possible. So we want to increase the cerebral perfusion pressure. But because of these hematomas, if the intracranial pressure is high, it is putting pressure on the blood supply vessels to the brain. And if the blood vessels supplying oxygen to the brain are compressed, then oxygen is not going into the brain cells. So if we release this intracranial pressure, then the pressure on the vessels will be relieved, and then the oxygen supply to the brain cells will be proper. Normally the intracranial pressure is 8 to 12 millimeter of mercury. More than 22 can be dangerous, so we try to keep it somewhere below 20 millimeter of mercury, preferably around 15 millimeter of mercury. For doing this or reducing the intracranial pressure, we give mannitol, or we can use diuretics. Mannitol is the osmotic diuretic of choice. If medicines are not helping, then we can create some burr holes and drain the hematoma and release the intracranial pressure. If this is also not helping, then we can simply do a craniotomy. We can open the cranium and we can evacuate the hematoma so as to release the intracranial pressure. Right. So Dimpy from Orenburg has asked that I should give the examples for early and late intervention. Let us just imagine a scenario, Dimpy, that early intervention would be needed when the patient is actually dying very soon. Suppose there is a blunt trauma to the abdomen, and suppose liver and spleen are injured. There is massive amount of bleeding and the patient is going to die very soon, maybe within 10 minutes, 15 minutes or half an hour or 1 hour. Then even by pumping in IV fluids, if the blood pressure is not coming up, let us take this patient in the operation theater, do an immediate intervention and stop the bleeding by exploration. That is red category. However, many times we see that there is injury to the organs inside, the bleeding is going on, but the bleeding is not massive. We are pumping in IV fluids, the patient is able to restore some amount of pulse and blood pressure, but not to the normal extent. So we are trying to do the resuscitation. If the patient is not responding nicely, but still patient is responding to some extent, we can wait for some time. We can continue with our resuscitation. Maybe the patient may respond, maybe the bleeding might stop, because platelets and clotting factors will form a platelet plug out there. If the bleeding stops, no intervention would be required. But if the bleeding continues despite all these measures, even after a few hours, maybe after 6 hours also, then we might have to do exploration and we might have to apply direct pressure and control the bleed. That would be early intervention, yellow category. Right. Fine. So for the doubts, I think I would be taking up in the today evening when the class will finish. Then I'll be taking more doubts, whatever you have. So we were just trying to reduce the intracranial pressure by different methods. Lumbar puncture is best avoided because this can increase the risk of herniation. So this is what we discussed in our last class. Now, moving from the head, let us come to the face and let us try to understand better. Face can be divided into upper face and the lower face. Now this lower face is actually the mandible. In the upper face, there are Lefort fractures which are discussed in your ENT classes. In the lower face, that is the mandibular fractures. It is the condyle of the mandible which gets injured most often. Second most common injured is the angle of mandible. A dangerous fracture of the mandible is a symphysis menti fracture. Symphysis is the term beta which we use where two bones unite. For example, in your pelvis, where the two pubic bones unite, we call it as pubic symphysis. So here where the two mandibles unite, this junction is called as the symphysis menti. This is a dangerous fracture because the genioglossus muscle is inserted on the inner aspect of this symphysis menti. Whenever this gets fractured, the insertion of the genioglossus muscle is lost, because of which the tongue falls back and closes the airway and the patient dies. So we have to be very careful, especially when we are seeing these symphysis menti fractures. In order to see these mandibular fractures, we can take a special X-ray where we can see both the mandibles in one view. Both the mandibles can be seen in one view. For example, if I just try to show you this image here, if you just carefully have a look at this particular view beta, can you appreciate? You can see both the mandibles. Can you see this mandible here? Can you see the other mandible here? Both the mandibles in one view. This is called as orthopentamogram. Beta, this has been an image-based question in your exam. So please have a nice look at this image. This what you are seeing on the screen, this is an orthopentamogram. In this particular picture, you are seeing that there is a fracture seen here. Okay. Now, what should be done for these fractures? If we just take a look at the basic concepts of fracture treatment, whether it is a humerus fracture, tibia fracture, femur fracture, whatever it is, we just want that the fractured ends, suppose this was the humerus, or let me just expand myself and try to explain this concept better. Suppose this is the bone, right? And now if there is a fracture, there may be a possibility that it has come somewhat like this. An orthopedician is just supposed to align the two fragments of the bone right next to each other. The healing will be done by God with the help of callus formation. Okay, so we have to just align the two fragments. Now this can be done either without doing any surgery. We can do a closed reduction. For example, if there is a fracture of the humerus here, then we can apply some traction here and try to bring the two ends of the humerus right in front of each other. If this is not possible, then we have to do surgery, open that area, do an open reduction, and then fix this either by using some plate and screws, or you can put a nail or a rod to fix these fractures. So the same story is what we want to apply in the treatment of these mandibular fractures. In these mandibular fractures, if we just try to take a look at what we are supposed to do in the treatment here, if this is the fracture here, if suppose the teeth of the patient are intact, then we can simply do interdental wiring. We can use a wire and we can fix the teeth with the help of this wire. Just by doing an interdental wiring, this will help in aligning this segment right next to this segment, right? So if the teeth of the patient are intact in the accident, then we can simply do interdental wiring and align the two fractured mandible ends. But if by chance the patient has lost teeth in the accident, then we will not be able to do this interdental wiring. In these situations, we have to do some surgery wherein we can put a plate we can use a plate, something like this, and then we can tighten this plate with the help of screws. So that is how we can treat these mandibular fractures, right? Let's take a look what all is written in the mandibular fracture story. समझ में आया बेटा? I hope you are able to understand this. In the face beta, we have divided the face into upper and lower face. Upper face, this is the Leaford fracture 1, 2 and 3. Lower face, this is the mandibular fracture what we are talking about. These Leaford fractures beta, they are discussed in your ENT class. Mandibular fracture, most commonly it is the condyle which is getting injured. Second most commonly it is the angle of mandible which is getting injured. Most dangerous is the symphysis menti fracture, and this is because genioglossus muscle insertion can be lost and this can block the airway. Herein, please do mention beta, safety muscle of tongue. Safety muscle of tongue. This is genioglossus. You can also make a note beta, safety muscle of larynx. Safety muscle of larynx. This is posterior cricoarytenoid. Posterior cricoarytenoid. Now herein, the investigation what we are commonly doing to see both the mandibles is OPG, and this OPG beta, this is the orthopentamogram. This is the orthopentamogram. However, please remember beta, best investigation would be a CT scan. Best investigation would be a CT scan. Now if we look at what would be the treatment in these patients, if the patient has got teeth intact, then we can do interdental wiring. But if the patient has lost teeth in the accident, then we do a open reduction and internal fixation with the help of plates and the screws, right? Okay. Now let us move towards the neck. In the neck, let me just try to explain the neck trauma first, and then we'll be seeing what is written in the workbook. So beta, in the neck trauma, if we just try to understand, this neck is protected above by the face and below by the chest. So when we are talking about blunt traumas means suppose there is a car accident. अगर मान लीजिए गाड़ी का एक्सीडेंट हुआ, or maybe for example somebody falls on the road, एक आदमी सड़क पे गिर जाता है. Now either there would be injury to this head or face area, or maybe injury to the chest area, but neck is usually saved. However, in the neck, it is the cervical fracture, cervical spine fracture, which we can see commonly in blunt traumas. And cervical fractures, beta, we know they require immediate immobilization by using a cervical collar, right? So blunt traumas to the neck, it is usually the cervical spine injuries which we can come across. However, there can even be a penetrating injury. Penetrating injury beta, that is something with a sharp object. For example, suppose this particular thing what you're seeing here, now this thing what you're seeing beta, this looks to be a little sharp. If this would have been more pointed, this would have been really sharp. And suppose there is a trauma to the neck with this sharp object. Suppose this is a knife. Now, it depends which part has been injured, right? We can divide this neck into 3 zones, what you are seeing in your workbook, beta. Here there is a suprasternal notch. Then here it is the cricoid cartilage. So this is called as zone 1. From the cricoid cartilage right up to the angle of mandible, this is zone 2. That means this area what you're seeing is zone 2. Zone 1 is from suprasternal notch to cricoid. Zone 2 from cricoid to angle of mandible. And zone 3 from angle of mandible to the base of skull. So this area, trauma to the neck area in this region will be the zone 3. If there is injury with this type of sharp object in the neck, then what is going to happen? This might cause injury to some of the major blood vessels. If major blood vessels are going to get injured, beta, you can imagine that this is going to cause severe bleed. And because of this severe bleed, the patient can even die, right? So, if the patient is hemodynamically unstable, then we have to immediately explore these patients. Also, I would like to tell you, beta, that suppose you are standing on the side of the road and suddenly you see a fight amongst 2 groups. And suppose suddenly somebody comes with a knife and hits the knife in the neck. अगर किसी ने ऐसे चाकू मार दिया गर्दन में, and suppose the knife is left inside. मान लो कि वो चाकू गर्दन में छोड़ के भाग गया. Now, this knife inside, the patient may be coming towards you with a knife in the neck and he may be asking you, doctor, please do something for this. Would you like to take this knife out on the road? Never. Never ever we take these foreign bodies out on the road or without any precautions. All these foreign bodies, whether it is in the neck or maybe in the chest or maybe in the abdomen, they should be taken out inside the operation theater under full vascular control. Okay? There is a possibility that if suppose somebody has hit a knife and there is bleeding inside, the blood may get clotted around the knife. And this clot is putting direct pressure on the vessel. Because of this direct pressure, the vessel is not bleeding and the patient is stable. But if you try to take this knife out without precautions, soon what can happen? The clot can dislodge. And if the clot dislodges, the vessel will start bleeding again. And there might be massive bleeding because of which the patient can die. So it is not because of the person who is hitting the knife, but because of the person who is taking the knife out, that massive bleed has occurred and patient has died. Moral of the story, beta, मारने वाले की वजह से नहीं, बल्कि निकालने वाले की वजह से patient की death हो सकती है. इसलिए we should not remove these foreign bodies without vascular control, right? There might be scenarios that somebody has hit a knife and maybe the force used while hitting is not much and this has not caused any significant injuries inside. If the patient is stable, no problems to the patient, and if suppose the knife is also not inside, the person has taken the knife and he has run away already, there is just a wound in the neck, patient is stable, generally these patients can be managed without operation, conservatively. Right, Bitta? Okay. Now let's see what all is written in the neck trauma. Blunt trauma to the neck, Bitta, and penetrating trauma. Blunt trauma, there can be injury to the cervical spine, which will require immobilization by a cervical collar. Penetrating trauma, the neck can be divided into 3 zones, beta. Once again, if you take a look here, this is the suprasternal notch, this is the cricoid cartilage, this is the angle of mandible, and here would be the base of skull. So this is zone 1, which is between the suprasternal notch and the cricoid. This is zone 2, between the cricoid and the angle of mandible. and this is zone 3, above the angle of mandible to the base of skull. Trauma to any of these areas, penetrating trauma to any of these areas, if the patient is stable, no operative intervention is needed. But if the patient is unstable, then definitely surgical exploration is needed. If foreign body is left inside, then also proper exploration is needed, and removal of foreign body should be done inside the operation theater under full vascular control. Right. So these are the 3 zones what we are seeing here. If the patient is hemodynamically unstable, then immediate surgical exploration would be required. However, if the patient is hemodynamically stable, we can do some investigations and proceed accordingly. Generally, the treatment is non-operative. You can add one point here, beta, that foreign body in penetrating traumas should be removed in operation theater. How to decide whether the patient is stable or the patient is unstable? For this beta, we can simply calculate a shock index. Shock index is a ratio of pulse to systolic blood pressure. Beta, can you repeat? Shock index क्या होता है beta? What is shock index? Ratio of pulse to systolic blood pressure. अच्छा बेटा जी, please tell me what is your pulse rate right now? आपकी pulse कितनी बेटा? Okay, suppose it is 70 beats per minute. What is your systolic blood pressure beta right now? 120. Your blood pressure is 120 by 80, so systolic is 120 and diastolic is 80. Now, if I divide the pulse by systolic BP, tell me beta, this ratio is what? Less than 1? 1 or more than 1? So this ratio is less than 1, right? Now, let us just imagine a situation where the patient is having some trauma, and this is the blood vessel which I have drawn, and suppose this is the wall of the blood vessel. Because of injury, the blood is leaking out. Blood is leaking out. That means the intravascular volume is going down, beta. As soon as the intravascular volume is going down, that means oxygen supply to different cells of the body is going down. So immediately what happens? The heart responds to this situation, and immediately the heart starts pumping faster and faster, faster and faster, faster and faster. And because of this, the heart rate is increasing, right? Immediately what happens? The blood vessels in the skin, they will constrict in order to throw more blood towards the important organs in the body, right? So, tachycardia is a earliest sign of hypovolemia. And gradually, beta, what will happen to blood pressure? If the intravascular volume is going down, then obviously the pressure exerted by the blood on the wall of the vessel will also be going down. That means in a trauma patient, in a bleeding patient, immediately what happens? The heart rate starts increasing. And gradually, if the blood is getting lost continuously, more than 30% of blood loss has occurred, then the systolic blood pressure also starts falling down. That means, beta, if suppose we are talking about a trauma patient, the pulse rate will increase. Suppose the pulse rate increases to 100 and the systolic blood pressure decreases. Suppose it comes down to 100. Then the ratio is 1. If the bleeding is going on, beta, the pulse rate is further increasing, 120, and systolic blood pressure is going down. Suppose it has gone down to 80, then this ratio has become less than 1. If this ratio is 1 or less than 1, then we say that patient is hemodynamically unstable. If this ratio is less than 1, sorry. If this ratio is less than 1, then we say that patient is hemodynamically stable. Right, beta? So, if this ratio is more than 1, then the patient is hemodynamically unstable. Patient is hemodynamically unstable. Right? Fine, beta. Now, from the neck, let us move towards the chest. And if we talk about the chest, beta, then in the chest, there are so many important organs. If you just try to take a look at what all is present inside your chest, beta. Now, suppose we talk about this particular picture. What we can see here is there are ribs, and beneath the ribs, we know there are lungs inside. We know there is a heart. We know there is trachea, bronchus, esophagus. We know there are major vessels lying in this chest. So in chest trauma, there can be injury to any of these structures, beta. Either there can be injury to the rib cage, that is the ribs, or there can be injury to the underlying organs, maybe the lungs, heart, major vessels, trachea, bronchus, and so on. Out of all these organs, what is commonly injured in chest trauma, beta? Let us just try to imagine a situation where suppose there is a road traffic accident. कुछ imagine करने की कोशिश करते बेटा कि कोई accident हुआ है. Now, ribs are the most common things to get injured in the chest. The examiner may ask you, अच्छा, which sided rib fracture is more common, right sided or left sided? So just try to raise the hands if you are right-handed. Like I am right-handed. Okay. Now this is an online class, but if it is not an online class, and if suppose all the students are sitting together, then you will find that majority of the individuals are right-handed. So what is the inference here? If a person is falling on the right side, since majority are right-handed, these people can take the support of their hand when they are falling, and that is how they can prevent the trauma to their right rib cage. But if the person is falling on the left side, then this person may not take adequate support from the left hand and may land up in injuring the left rib cage. So beta, right side or left side, कौन सी rib fractures will be more common? Which rib fractures are more common? It is the left side, and usually 4th to 9th ribs are fractured. I would like to remind you, beta, that if the rib is getting fractured, the fractured end of the rib, this is going to put pressure inside or penetrate inside and may cause injury to the pleura or to the lungs. Now, if we take a look at this particular image, normally, beta, suppose I say that this is the lung. Here, still it is seen compressed, but ideally this lung should have been present somewhat like this. Similarly, the other side of the lung would have been somewhat like this, right? So ideally the lungs should have been seen like this. But because of this rib fracturing, this can cause injury to the pleura or to the lungs or to the blood vessel. If the lung is getting injured, beta, the air will leak out, and this air will start getting collected in the pleural cavity. So this air is getting collected in the pleural cavity, and this is going to put pressure on the ipsilateral lung, on the same side lung. And as you can see, beta, this side lung, only this part is remaining, rest entire lung has been collapsed, right? So if the lung is getting collapsed, definitely the oxygen is reaching only to this part of the lung. That means the patient will have some difficulty in breathing. Or if I say that it is not air, suppose there is injury to the blood vessel, beta, and if suppose the blood starts getting collected, now the blood is getting collected here. This is also going to put pressure on the ipsilateral lung. And you can see here also the lung has collapsed. Whether it is collection of blood or it is collection of air, beta, this is putting pressure on the ipsilateral lung, and the ipsilateral lung is getting collapsed, because of which the patient is having difficulty in breathing, which we call as dyspnea. Acha beta, air in the pleural cavity is called as pneumothorax. Blood in the pleural cavity is called as hemothorax. एक बार फिर से करेंगे बेटा, we'll do it once again. Air in the pleural cavity is called as, very good. Blood in the pleural cavity is called as hemothorax. Well, wonderful. Good. So ये basic concept is there inside us. Now, let us imagine the situation that this patient has come to you in emergency. So February 2023, 17th of December is your exam, beta. You are definitely going to clear the exam if you follow the consistent path, if you try to understand the concepts right. So by 31st December, your results are going to be out. And in the month of January, you will be getting your passing certificate. February, you will be applying for your registration in the respective state medical council, and many of you would start working in the hospital, right? Now, this patient comes to you with some difficulty in breathing. Remember, beta, in this particular patient, the other lung is absolutely normal. That means whatever oxygen is coming here, that would be nicely going into the blood. But because of this side lung collapse, he is not able to have complete normal breathing. So what we want to ensure is normal breathing. How do we come to know? We can do some clinical examination. For example, inspection, palpation, percussion, auscultation. On palpation, beta, we may hear that cud type of sound. We may hear some crepitus type of sound because of the rib fracture. Then we can do percussion, beta. And percussion is something which is done with middle finger. The examiners in NEET PG, they have asked, beta, that in percussion is done with which finger? Is it the index finger? Is it the middle finger? Is it the ring finger? Or is it the little finger? So these are the four options. Percussion, beta, is done with the middle finger. And then they can ask you percussion is done on which finger, whether it is the index finger, middle finger, ring finger, or the little finger. So beta, percussion is done with the middle finger, on the middle finger. Percussion is done with the middle finger, on the middle finger. Then they may ask you, in percussion, the movement occurs at which joint? And the options can be interphalangeal joint, or the metacarpophalangeal joint, or the wrist joint, or the elbow joint, or the shoulder joint, or the hip joint. So the answer is elbow joint. Movement in percussion occurs at elbow joint. For example, if I demonstrate it here once again, this is how we are doing the percussion. Now the note which you are hearing, if there is air inside, then you will hear a loud note. That is a tympanic note. If suppose there is air in this pleural cavity, then you will hear a loud note, tympanic note. But if there is fluid, like here, if there is blood, then because of the fluid, because of the blood here, the note will become dull. Okay, so a resonant note, loud note, tympanic note is heard in cases of pneumothorax or hemothorax. Yes, everybody. pneumothorax. And a dull note is heard in, very good, whenever there is any fluid, hemothorax, dull note. What else you can do, beta? You can do the auscultation. Now in auscultation, when we do the auscultation, beta, generally for lungs, we ask the patient to turn towards the other side. Suppose patient is sitting in front of you on the stool. Then anteriorly, you try to hear for the heart sounds, and posteriorly, you try to hear for the breath sounds. Now, an important thing, beta, if you just look at this image and you are doing the auscultation, okay, wherever you are able to find the lung, if you keep your stethoscope here, you will hear a normal breath sound. Here, 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 again, normal breath sound. Here, normal breath sound. Here, normal breath sound. Here, normal breath sound. But what about here? What about here? What about here? What about here? If there is no lung shadow here, if there is no lung here, you will not be able to hear the breath sound in this area. So on auscultation, beta, if the lung is collapsed, then you will not be able to hear the breath sound, right? That is how you can get an idea. On percussion, by hearing the note, you can make an idea whether it is a pneumo or a hemothorax. And on auscultation, beta, reduced or diminished breath sounds will indicate that how much lung is collapsed. Whether it is only one side partial collapse, or it is one side complete collapse, or it is both side partial collapse or both side complete collapse. So this auscultation will give you some or the other idea, right? Once you're done with the clinical examination, a simple investigation, what you can do is a chest x-ray. Now in the chest x-ray, beta, please remember that air appears black. Air appears black on x-ray. Like here in this particular case, what you are seeing here, this black shadow, what you're seeing, or I think because of the logo, this is creating some issue. Let us see the workbook. Yeah, if you just try to focus in here, beta, yeah, now this is a better picture. Or if suppose we take here on this side, right? Air appears black on X-ray, right? So on this side, if you see, you can see some more black shadow in this particular area. This area, what you're seeing, beta, this area looks to be more black. So probably this is a collection of air, that is pneumothorax. Also, what you are seeing, beta, why we are saying that this is not the lung shadow, but this is an air collection, because if it would have been a lung shadow, you could have seen the bronchovascular markings. Now here in this X-ray, beta, can you appreciate that there are markings of the blood vessels on the surface of the lung? Okay, here you are able to see those bronchovascular markings. Here also you are able to see the bronchovascular markings in this area, but you are not able to see any bronchovascular markings in this area. So if you are not able to see any bronchovascular markings in this area, that means this is not a lung shadow. Lung is actually collapsed in this case. The lung is collapsed like this, right? It is being pressed by the air from outside, air from the pleural cavity. Okay, so that is how we can identify whether it is a normal X-ray or it is a pneumothorax. On this side, you are seeing the nice bronchovascular markings all over, but this side you are able to see the bronchovascular markings in this area, but not in this area. So this blackness, what you are seeing, this is a pneumothorax. Now, if there is fluid collection, suppose, say in trauma patient, we are talking about blood collection. Fluid or blood appears white on X-ray or CT. And we know that fluid or blood is going to collect lower down. So this whole area is appearing white to you. All this what you're seeing, beta, this white area, this is actually a liquid collection in the pleural cavity. And if this case is related to trauma, most likely this would be blood. That is why it is appearing white. Another important thing to see in this is, whenever we are taking a X-ray, we can see a nice costophrenic angle. For example, here in this particular X-ray, can you appreciate that there is a nice costophrenic angle? This angle, what you're seeing, this angle, right? If suppose there is collection of fluid or maybe collection of blood, then what will happen? This area will appear white and we will not be able to see the costophrenic angle properly. That means there will be blunting of the costophrenic angle. This blunting of the costophrenic angle also suggests, beta, that there is some liquid collection or blood collection in this particular area. Okay, so we have seen two X-rays, one of pneumothorax, another of pleural effusion, or you can say hemothorax in a trauma patient. I hope, beta, you will be able to identify these X-rays in your exam. Please mind my words, 17th of December, you will be getting one image from these X-rays. May not be the X-rays what you're seeing right in front of you, but maybe from one of the pictures, one of the images available on Google. So I request all of you, beta, to see as many X-rays as possible for pneumothorax, tension pneumothorax, hemothorax, right? I repeat, beta, if you see this particular X-ray here, you can nicely appreciate that there are good bronchovascular markings seen all over this. But here on this side, you are seeing bronchovascular markings only in this area. You are not seeing any bronchovascular markings in this area. You are seeing this area is more black. So this is the case of pneumothorax. While if it is a hemothorax or a pleural effusion type of story, you are seeing that white haziness in the lower part. Plus you are seeing blunting of the costophrenic angle here. That is how we make out these pneumothorax and hemothorax. However, having said that, best investigation would be a CT scan. Okay. Now, once we have made the diagnosis, beta, then we have to do the treatment. And in the treatment, beta G, क्या करना चाहते हैं हम? In the treatment, what we want to ensure, we want that if this is the story, we don't want this collection inside. We want that this lung, what we are seeing here, this lung should expand nicely and this lung should be present like this. This is what we want to achieve. Yahi chahte na beta? Now, in order to do this, what we have to do is we have to drain the collection. To drain the collection, beta, you can simply put a intercostal tube. You can put an intercostal tube. Usually this tube is put in the 4th or 5th intercostal space, just anterior to the mid-axillary line. If we take a look where we are putting the tube, beta, see this particular picture. Now here, this is the axilla, right? If you take a line from the anterior border of the axilla, this would be the anterior axillary line. If you take the line from the middle of the axilla, this will be the mid-axillary line. If you take a line from the posterior axilla, this is the posterior axillary line. Where we are trying to put the tube, beta, we are trying to put the tube in this area. That is in the 4th or 5th intercostal space, just anterior to the mid-axillary line. And when we are putting the tube, we are putting it along the upper border of the lower rib. This what you are seeing here, this is the catheter what we use. I hope you are able to see this catheter nicely. This is the catheter what we are using as the intercostal tube. The size of this catheter is approximately 28 to 32 French. So we are going to put this catheter in the 4th or 5th intercostal space, just anterior to the mid-axillary line, along the upper border of the lower rib. Now the question is, beta, that if suppose you have put a catheter here, the outer end of the catheter, the outer end of the catheter, you cannot leave it exposed to the atmosphere. अगर हमने मान लीजिए ट्यूब डाली है और जो बाहर वाला हिस्सा है वो एटमॉस्फेयर को एक्सपोज्ड है, then outside pressure is positive and inside pressure is negative. तो बेटा बताओ, just tell me बेटा, if you just put a tube like this and the outer end is exposed, outer pressure is positive. So what will happen? The outside air will start going inside and will further increase the pneumothorax. So we cannot keep the outer end like this, beta. What we do is, there is a special type of tube wherein the outer end of the tube is actually dipped in a water column. The outer end of the tube is actually dipped inside the water column like this. Okay, so if the outer end of the tube is in the water column, then what will happen? This is not exposed to the air, so the outside air will not be able to go inside, right? This is what we call as a underwater seal bag. Underwater seal bag. क्या बोलते बेटा? What do we call this? Underwater seal bag. So that is how, what we are trying to do here, beta, we are just trying to put an intercostal tube and we are going to drain this collection out. As the collection is going out, beta, what will happen to the lungs? The collection is going out. And see what actually happened in this case. Because of the hemothorax or the pneumothorax, this is the lung shadow what you are seeing. The lung collapsed like this. That is why the patient was having difficulty in breathing. Now you have put a drain. So the drain is draining all this collection outside. There is a space created here. You have to advise the patient for breathing exercises. If the patient starts doing the breathing exercises, then the air will keep on entering into the lung. There is a nice space available here. So gradually this lung will start expanding. As this lung will start expanding, the story will become almost normal, something like this. And once the story becomes normal, something like this, then you can remove the intercostal tube. So that is what we want to achieve in case of chest trauma. We want the lung to expand. I just repeat this in Hindi also once, beta, because this is an important conceptual area. ध्यान से सुनिएगा बेटा, जब भी हम चेस्ट ट्रॉमा की बात करते हैं ना, तो चेस्ट ट्रॉमा में क्या हुआ? मान लो पसली टूट गई. पसली के टूटने से जो टूटा हुआ पसली का एंड है वो अंदर प्लूरा को या लंग्स को चोट पहुंचा सकता है. उसकी वजह से हवा निकल सकती है. हवा प्लूरल कैविटी में कलेक्ट हो जाएगी तो न्यूमोथोरैक्स. हो सकता है ये टूटी हुई पसली ब्लड वेसल को इंजर करे तो ब्लड कलेक्ट हो जाए प्लूरल कैविटी में, तो वो हो गया हीमोथोरैक्स. अब चाहे न्यूमो हो बेटा या हीमो हो, प्लूरल कैविटी में अगर कोई भी कलेक्शन आ रहा है ना, तो ये उस तरफ के गुब्बारे को दबा रहा है. गुब्बारा मतलब ये जो लंग्स है ना बेटा, ये हवा के गुब्बारे हैं, है ना. दे आर एयर बैलून्स. अगर आप इनको फुलाते हैं बेटा तो ये गुब्बारे फूलते हैं. अगर मान लो किसी दिन अपना मूड खराब हो जाए कि यार ये क्या है, ये रोज रोज का क्या तरीका है, रोज रोज सांस क्यों लेनी पड़ती है, जाओ आज हम सांस नहीं लेंगे, नहीं लोगे तो गुब्बारा नहीं फूलेगा. गुब्बारा नहीं फूलेगा तो ऑक्सीजन जाएगी कैसे, और ऑक्सीजन जाएगी नहीं ब्लड में तो फिर हम जिंदा कैसे रहेंगे, तो हम मर जाएंगे, है ना. तो हम क्या चाहते हैं, गुब्बारा अच्छी तरह से फूलना चाहिए. अब चाहे हवा भर गई हो चाहे ब्लड भर गया हो, हम एग्जामिनेशन में परकशन से पता लगा सकते हैं. अगर आवाज तेज है तो हवा है, अगर आवाज दब रही है तो ब्लड है. ऑस्कल्टेशन पे जहां भी गुब्बारा होगा वहां पे तो ब्रेथ साउंड आएगा, लेकिन अगर गुब्बारा फुस हो गया है और बाकी इलाके में आप ऑस्कल्टेट कर रहे हैं तो वहां पे आपको ब्रेथ साउंड सुनाई नहीं देंगे. हमने इसके इलाज में क्या किया, हमने फटाक से तो एक्सरे ले लिया और कंफर्म कर लिया. अगर नहीं कंफर्म होता तो सीटी कर सकते हैं. इलाज में हम यही चाहते हैं कि जो गुब्बारा है वो पूरी तरह से फूल जाए. उसके लिए हम 4th 5th इंटरकॉस्टल स्पेस में ट्यूब डाल देते हैं और जो भी सामान कलेक्ट हुआ है उससे ट्यूब से बाहर निकाल देते हैं। ट्यूब का जो बाहर वाला सिरा है वो पानी के अंदर होता है। एक बैग होता है जिसके अंदर एक पानी का लेवल होता है, उसमें पानी डाला जाता है। ट्यूब का जो बाहरी सिरा है वो उस पानी के अंदर होता है, जिससे बाहर की हवा अंदर ना जा सके। तो जैसे जैसे हमारी हवा या ब्लड ड्रेन हो गया, वैसे वैसे जगह क्रिएट हो गई। फिर हम पेशेंट को सांस लेने को बोलते हैं, लंबी लंबी सांस लीजिए। लंबी लंबी सांस लेते हैं, या कोई स्पायरोमीटर वगैरह दे देते हैं, या फुटबॉल का ब्लैडर देते हैं फुलाने को, फुग्गा फुलाओ। तो फुग्गा फुलाने से क्या होता है, ये लंग एक्सपैंड होता है। या बाबा रामदेव जी जो हैं हमारे, उनकी एक्सरसाइज बता देते हैं। तो उस तरह से गुब्बारे को फुलाना जरूरी है। कॉन्सेप्ट ये है बेटा कि जो ये गुब्बारा है इसको फूलना होगा, तभी तो ऑक्सीजन इस गुब्बारे में अच्छी तरह से जाएगी। और जब इस गुब्बारे में अच्छी तरह से ऑक्सीजन जाएगी तभी तो ये ऑक्सीजन वहां से ब्लड में जाएगी। तो आई होप बेटा यू हैव अंडरस्टूड दिस concept of chest trauma nicely, and I hope beta that you remember this concept on 17th of December, right? Chale, so this is the story about pneumothorax and hemothorax. अच्छा, let us talk something about tension pneumothorax। यहाँ पे अभी टेंशन pneumothorax में बेटा let us just imagine that suppose there is a stab injury। स्टैब मतलब सपोज करिए somebody has hit a knife, किसी ने चाकू मारा है। somebody hits a knife into the chest. Now what will happen? If suppose there is a open wound in this area, and you know that outside is positive pressure, inside is negative pressure, so air will continuously be going inside, and this is going to put pressure on the ipsilateral lung. So you can see that ipsilateral lung has almost collapsed. When there is huge amount of air going from outside to inside, it is not only the ipsilateral lung which is facing the pressure, but even the mediastinal structures like the trachea, esophagus, heart, everybody is facing this pressure. And because of continuous pressure by the air, this mediastinum is also going to shift to the opposite side. And when this is getting shifted to the opposite side, it is also putting pressure on the opposite lung. That means the opposite lung is also getting compromised. This lung is already collapsed. The opposite lung is also getting compromised. That means the oxygen is not going inside this patient. The situation is something like somebody has put a handkerchief or maybe some cloth over the mouth and the nose. अगर आपने किसी का मुंह नाक दबा दिया तो ऑक्सीजन इज नॉट गोइंग इनसाइड, एंड दिस पेशेंट इज गोइंग टू डाई क्विकली. दिस टेंशन pneumothorax, a situation where it is not only the compromise of the one side lung, but it is also the compromise of the opposite lung. Here the patient is not able to breathe at all. This patient is going to die very soon. We do not have minutes or hours to save this patient. ध्यान दीजिएगा बेटा, be careful. February 23 when you will be practicing in the hospital, by chance this patient comes to you in the emergency and patient is actually dying. You are seeing that he's dying. And if you suspect that this can be because of some tension pneumothorax, you see there's a wound and air is continuously gushing inside, what you can do beta, you can quickly put a needle into the intercostal space. You can simply put a needle into the intercostal space. As soon as you put a needle into the intercostal space beta, just the wide bore needle, this was the question asked on 4th of June 2022. They gave this type of scenario. And then they asked, what should be done immediately to save the life of this patient? As soon as you put the needle here, beta, whatever air is there inside under pressure, this air might start going out from this needle and the air might come out. And some pressure on the lung may be released. थोड़ा सा pressure lung से release हो सकता है. And if you can release some pressure, patient can take oxygen. You get precious seconds and minutes more to do something to save the life further. That means tension pneumothorax is a situation which is a dire surgical emergency, where the patient is in respiratory distress, where the patient is actually dying. We don't have time to see where is the tube, how to put the tube and all that stuff. We can just pick up the widest bore needle available in the emergency and put this needle into the 4th, 5th intercostal space just anterior to the mid-axillary line. Try to evacuate some air from inside so that some pressure on the opposite lung can be released, and if some pressure on the opposite lung is released, some oxygen can go inside and we can buy some minutes where we can put the proper intercostal tube. Right, beta? To save the life in tension pneumothorax, we don't have so much of time to see for the tube or put the tube. We just pick up the widest bore needle available in the emergency and put that needle inside. This needle in tension pneumothorax, in case of adults, it is put in the 4th, 5th intercostal space just anterior to the mid-axillary line. But in case of children, this needle is put in the 2nd intercostal space in the mid-clavicular line. This is for needle insertion in tension pneumothorax. It is not for tube insertion in just a simple pneumothorax or hemothorax. In a pneumo or hemothorax, we are putting the tube in the 4th, 5th intercostal space just anterior to the mid-axillary line. Right, this what we are discussing, beta. This is according to the ATLS guidelines, Advanced Trauma Life Support Guidelines. These guidelines may be different from the guidelines mentioned in the standard textbooks of surgery like Bailey and Love. These guidelines may be different from what you have read in your college, in your graduation. Okay? But for 17th of December and in our clinical practice, we are following these ATLS guidelines for the entire trauma. Another thing, beta, which I would like to tell you in tension pneumothorax, what is happening here, as we can see. Now, because of massive collection of air here, there is pressure on the opposite mediastinum also. So what is happening? Even the major vessels around the heart, these vessels are also getting compressed. You know, heart has got 4 chambers, beta. Right atrium, right ventricle, left atrium, left ventricle. In the right atrium, all the venous drainage occurs. Superior vena cava, inferior vena cava, they open in the right atrium. Now, superior vena cava is bringing the blood from the head and neck and the upper limb area. If suppose somebody has pressed the superior vena cava, then venous return is not going into the heart. All the blood is getting pulled into the veins above. So if the blood is getting pulled into the veins above, these veins which would have been normally something like this, now because there is a pressure on these veins, there is a pressure on the superior vena cava, the venous drainage is not occurring properly and these veins will get abnormally dilated and tortuous. These veins are going to be abnormally dilated and tortuous. That means pressure in the jugular veins is going to increase. Raised jugular venous pressure can be seen even in tension pneumothorax. We would like to understand a situation of cardiac tamponade here. Cardiac tamponade जो होता है बेटा, cardiac tamponade is actually collection of blood around the heart in the pericardial cavity. Suppose there is injury to the heart and there is leakage of blood around the heart. Now just look at the screen carefully, beta. If this blood is getting collected around the heart like this, right, then this is going to put pressure on the heart and the heart will not be able to contract properly. Heart will not be able to pump the blood out properly. That means the pressure, blood pressure will be going down because there is hardly any pumping by the heart. So patient is going into hypotension. Also, this blood is putting pressure on the major veins, beta. So if these veins here, they are getting compressed, again, the venous return will not be proper. And if the venous return is not proper, we can understand that all the blood is going to get pulled in the veins above like this. So here also we'll find those engorged dilated neck veins. Here also we'll find that the jugular venous pressure has increased, right? So raised jugular venous pressure, hypotension, and when you put the stethoscope here, because of fluid collection all around the heart sounds are muffled. So heart sounds are muffled. Hypotension, muffled heart sound, raised jugular venous pressure is called as Beck's triad. Another question on 4th of June 2022, right? One thing which I want to make sure, beta, how to differentiate between tension pneumothorax and cardiac tamponade. In tension pneumothorax, beta, what is happening? We know that the ipsilateral lung has collapsed. The opposite lung is also facing the pressure. So when you are doing the auscultation, you are not able to hear the breath sounds properly, diminished breath sounds. But when you auscultate the heart, you will hear normal heart sounds in tension pneumothorax. While in cases of cardiac tamponade, beta, in cardiac tamponade where there is collection of blood around the heart, that means there is no problem in the lungs. So when you do the auscultation over the lungs, you will hear normal breath sounds over the lungs, but the heart sounds will be muffled in cardiac tamponade. So that is how we can differentiate these conditions. Right. Now let's take a look at what all is written in the workbook. So in cases of chest trauma, most commonly injured are the ribs. Left-sided rib fractures are more common. Usually 4th to 9th ribs are commonly injured. Pneumothorax, air in the pleural cavity. Hemothorax is blood in the pleural cavity. Hemopneumothorax is both air and blood in the pleural cavity. Tension pneumothorax we have discussed just now. We'll also be discussing the sucking wound and the flail chest a little later. So now if we take a look at pneumo and hemothorax, we can understand that if he's talking only about simple pneumo-hemo, then it is only one-sided lung which is getting under pressure. So patient may present with difficulty in breathing, that is dyspnea. Percussion is done with middle finger on the middle finger, and movement in percussion occurs at wrist joint. If on percussion you hear a resonant or a tympanic note, that means there is collection of air. That means this is the case of pneumothorax. However, if you find dullness on percussion, that means there is fluid. Like if we talk about trauma situation, it may be hemothorax. When we are doing the auscultation, breath sounds will be diminished if lung collapse is there. Breath sounds will be diminished if lung collapse is present. First investigation, generally what we can do is the chest x-ray, and on chest x-ray we can see a hyperlucency, that is more black, which is suggestive of pneumothorax. If you see white haziness along with blunting of the costophrenic angle, this would be a case of hemothorax. Investigation of choice in all trauma patients, beta, that is going to be CT scan. And I'm pretty sure that with the knowledge what we have tried to gain right now, we would be able to identify the images of pneumothorax, hemothorax, and tension pneumothorax. In tension pneumothorax, beta, what will happen? There will be huge amount of air collection on one side, and this is going to shift the trachea to the opposite side, so that the opposite lung will also be getting collapsed. In the treatment, beta, what we want to achieve, जो गुब्बारा फुस हो गया है उस गुब्बारे को फुला देना है. We just want to ensure adequate lung expansion. Normal breathing means what? Adequate lung expansion. This is what we have to achieve. And please do remember that for adequate lung expansion, we have to drain the collection, but just draining the collection is not enough. We have to encourage breathing exercises to this patient. सिर्फ कलेक्शन को निकाल देने से गुब्बारा नहीं फूलेगा। जब तक पेशेंट को समझाया ना जाए, गुब्बारा फुलाने की एक्सरसाइज ना बताई जाए, तब तक गुब्बारा नहीं फूलता है। It is not only just the drainage of collection, but it is also equally important to advise breathing exercise so that the lung can expand nicely. ध्यान रखना बेटा इसको। It is not only drainage of collection, but it is also breathing exercise which is going to be crucial. For draining the collection beta, we can put the intercostal tube drain. This is also called as tube thoracostomy, or you can also call it as tube thoracocentesis. Tube thoracostomy or tube thoracocentesis. Intercostal tube drain. This is put in the 4th or 5th intercostal space, just anterior to the mid-axillary line, in the triangle of safety along the upper border of the lower rib, along the upper border of the lower rib, and the outer end of the tube is connected to a underwater seal bag. This is what we are doing for pneumo and hemothorax. To promote breathing exercise beta, we can give spirometer or we can give football bladder, which will help in lung expansion. Just a passing reference beta, what we have been doing in our hospital. एक छोटी सी कहानी अगर हम देखें कि when I remember when I was working as a resident doctor in the hospital, we used to have around 7 to 8 patients at a time of this chest trauma, and all these patients were having that chest tube inside or that intercostal tube inside, and these patients, they never wanted to do breathing exercises and all that stuff. Why they did not want to do breathing exercise beta? Just try to understand this story as well. Why they never wanted to do the breathing exercises? Because in chest trauma there is rib fracture. Now if the rib is fractured beta, fracture is very painful, and if somebody tries to move the fracture part, the patient winces in pain, you know? And here you want to give breathing exercises to a patient who has fracture of ribs. Actually speaking, even without breathing exercise, patient has to inspire. So whenever there is any movement of those fractured rib, he is actually feeling quite uncomfortable. हर सांस में दर्द होता है, हर सांस में दर्द होता है. Patient does not want to breathe. So we have to ensure adequate analgesia in these patients. Adequate analgesia. So that there is no pain in the movement of ribs. Right? Okay. And once we have given adequate analgesia to these patients, then we promote these breathing exercises. Right? So let us go back to that story when I was a resident doctor, and there used to be 7-8 patients at a time in the chest ward, chest trauma ward. So all these patients used to have the chest tube inside. We were knowing that we have put a chest tube, so whatever the collection is there inside, that is going to drain out. But these patients are quite naughty. They are not going to focus on breathing exercise. So the lung is not able to expand properly. So just to encourage that lung expansion, we used to keep a competition in the chest ward. Competition of these 7 to 8 patients every day, 5 o'clock in the evening. We used to give them those pyrometers, and then we used to ask them to blow air into those pyrometers. Pyrometer is something beta which has got colored balls at the base. and if you blow air into that, then these balls, they rise up. So just imagine all those 7-8 patients sitting right next to each other, and we used to ask them to blow air into the spirometer. So we used to do this for approximately half an hour, and these balls used to rise up. And then after half an hour, we used to judge which patient's balls went the most up. And then we used to give some incentive to that patient, maybe a small dairy milk or something like that. So moral of the story, concept of this whole chest trauma is lung expansion. It is not just the drainage of the collection inside, but it is also the adequate lung expansion which you want to achieve, right? Okay. Right. Fine. So I hope, beta, this concept is absolutely clear in our minds. Now, sometimes we come across some serious scenarios, as soon as you put the chest tube inside, suddenly you see huge amount of blood coming out into the chest tube. अच्छा बेटा, can you tell me how much blood you are having right now? कितना blood है बेटा आपकी body में अभी? Very good. 5 to 6 liters. है ना? For standard values, we just take it as 5 liters. Now, suppose you put the chest tube inside and suddenly you see that, oh my God, more than 1.5 liter of blood has come out of the chest tube. Total is 5 liters inside this patient. 1.5 liter is already out. You are just looking at the tube. You are looking at the patient. Tube, patient, tube, patient. And if you just keep on doing like this, then you are seeing that huge amount of blood is actually coming out. Very soon all the 5 liter is going to come out and the patient is going to board the flight. That means if huge amount of bleeding has occurred, then we cannot just keep watching the chest tube. This is the indication, beta, that despite putting a chest tube, despite giving IV fluids, blood transfusion, tranexamic acid to these patients, the bleeding is not getting controlled. The patient is going to die very soon because of the bleed. So this is the time when you have to open the thorax. Open the thorax. Go inside the thorax and see that bleeding vessel right from your eyes. And then take direct control of that bleeding vessel. Direct pressure. That is how you will be able to save the life of this patient. Right? So, indication of opening the thorax is massive bleed or maybe injuries, major injuries to the trachea or to the bronchus or to the esophagus. Right, beta? So, if you take a look at indications of thoracotomy, what is written here? If there is more than 1.5 liter of blood, which has come at one instance in the first hour, or you can write this as more than 20 ml per kg in 1 hour. Or suppose there is more than 200 ml of blood coming out every hour, consecutively for more than 2 to 4 hours. This also indicates there is massive bleed inside, which we can write as more than 3 ml per kg per hour continuously for more than 2 to 4 hours. Or if there are major tracheobronchial esophageal ruptures, these are massive injuries which will require surgical exploration. Right? I repeat this in Hindi, beta. जब भी कोई चेस्ट ट्रॉमा वाला पेशेंट है और मान लो अंदर ब्लीडिंग बहुत ज्यादा हो रही है, जैसे अपन ने ट्यूब डाली और ट्यूब में अचानक से देखा कि भैया ये तो 1.5 लीटर से ज्यादा खून एकदम से बाहर आ गया है, यानी कि बहुत जल्दी पूरा 5 लीटर निकल आएगा और पेशेंट चला जाएगा, तो हम क्या देखते रहें? नहीं, हमें इसका तुरंत थॉरेक्स खोल देना चाहिए और थॉरेक्स खोल के अंदर जाना चाहिए और देखना चाहिए कि भैया ब्लीडिंग हो कहां से रही है, और जहां से ब्लीड हो रहा हो वहां पे पहले डायरेक्ट प्रेशर लगाना है और उसके बाद उसको जैसे भी सर्जिकली कंट्रोल करना है। ठीक है? या मान लीजिए 200 ml प्रति घंटा लगातार 2 से 4 घंटे अगर आ रहा है तो इसका मतलब भैया जो भी अपन पानी चढ़ा रहे हैं, जो भी उसको ब्लड चढ़ा रहे हैं, ट्रेनेक्सेमिक एसिड लगा रहे हैं, क्लॉटिंग फैक्टर दे रहे हैं, प्लेटलेट दे रहे हैं, किसी से भी ब्लीडिंग बंद ना हो रही, ब्लीड होते ही जा रहा है। अगर ऐसे ही चलने दिया तो सारा खून बह जाएगा, पेशेंट मर जाएगा। हमें तुरंत अंदर जाना चाहिए थॉरेक्स खोल के, और जहां भी ब्लीड हो रहा है वहां पे डायरेक्ट प्रेशर लगा देना चाहिए। ऐसे अपन को जिंदगी बचानी है। या कोई अगर मेजर ट्रेकिया ब्रोंकस इसोफेगस का रप्चर है तब अपने को थॉरेक्स खोल के उनको रिपेयर करना चाहिए, राइट? ओके, नाउ another story what we discussed was tension pneumothorax beta. This is a real surgical emergency. Real surgical emergency. In this, there is severe respiratory distress. Severe respiratory distress. This is because of massive air collection. It is not only the ipsilateral lung collapse or the mediastinal shift, but even the opposite lung is under pressure. Opposite lung is also under pressure. That means the patient is not able to actually breathe at all. This is associated with engorged dilated neck veins. The concept we understood, whether it is tension pneumothorax or cardiac tamponade, if somebody is putting pressure on the superior vena cava, then there will be engorgement, dilatation of the neck veins. The jugular venous pressure may increase. Just to save the life of this patient, as this is a dire surgical emergency, we do not have the time to put the tube. Just pick up the wide bore needle. Just pick up the wide bore needle and put this wide bore needle, 14 gauge needle if possible. In adults, we put this needle in the 4th, 5th intercostal space, just anterior to the mid-axillary line. In adults, we are putting this in the 4th or 5th intercostal space, just anterior to the mid-axillary line. And in case of children, we are putting this needle in the 2nd intercostal space in the mid-clavicular line. छोटे बच्चों में टेंशन न्यूमोथोरेक्स में नीडल जो डालते हैं वो 2nd intercostal space mid-clavicular line में डालते हैं. This is only for tension pneumothorax. For simple hemothorax or pneumothorax, we are actually putting a tube. The treatment, once we have put the needle, the final treatment for this tension pneumothorax would be putting a intercostal tube. नीडल डाल के इमरजेंसी रिलीव हो गई. अब जो भी हवा अंदर गई है उसको निकालने के लिए हमें ट्यूब डालनी होगी और पेशेंट को वही ब्रीदिंग एक्सरसाइजेस बतानी होगी. आई रिपीट दिस इन इंग्लिश बेटा. Just by putting a needle inside, you have relieved the emergency. You have got some precious seconds or minutes. Now you have got time to put an intercostal tube, and then you promote breathing exercises in this patient. And that is how the tension pneumothorax story will be relieved. We should be able to differentiate this tension pneumothorax story with cardiac tamponade. Cardiac tamponade, we can understand if there is any pericardial fluid collection, that means fluid collection around the heart. Maybe in trauma there might be injury to the heart and there is huge amount of blood around the heart, because of which the superior vena cava is getting compressed. We find engorged dilated neck veins, hypotension, muffled heart sounds, which is called as the Beck stride. That means on 4th of June 2022, you had two questions from the same page. This was a question and this was a question on 4th of June. So two questions from the same page we had. One, what is the treatment for tension pneumothorax? That is a wide bore needle insertion. And second, what is Beck stride? So this is engorged dilated neck veins, hypotension and muffled heart sound. This is also a real surgical emergency wherein we have to put a needle into the pericardial cavity and drain this pericardial fluid, which we call as pericardiocentesis. Pericardiocentesis. We put a needle into the pericardial cavity and drain the pericardial fluid so that pressure on the heart is gone and the heart can contract. we can understand that in pneumothorax stories, breath sounds will be diminished and there will be hyper-resonant note on percussion. In cardiac tamponade, breath sounds will be normal. Heart sounds will be muffled. Right. Now, in the chest trauma beta, there is another thing which is called as the sucking wound. Sucking wound is simple, as we were talking about the knife injury in the chest. For example, if suppose we just try to take a look at this particular picture, and herein, suppose somebody hits a knife into the chest like this. Now what is happening? There is an open wound in this area, and because of this wound, all the air from outside will actually be traveling inside. So all the outside air that is actually going inside. When you hear in this particular area, if you just put your ear in this area, you will find that if you just put your ear near to this area, यहाँ पे कान लगा के सुनेंगे, तो you will hear that air is gushing from outside to inside. Air is gushing from outside to inside, right? And in these cases, if suppose this patient is on the roadside where you are seeing this, then what you can do is you can just go to the quickly. You have to act very fast because huge amount of air is going inside. You can just look here and there. If you find some cafe, some restaurant or something, you can just ask for a silver foil from that cafe, and you just bring that silver foil and put that silver foil somewhere here like this. Suppose herein there is a wound here, the outside air is going inside. So what you have done is you have just bought a silver foil from a cafe. एक कैफे से अपन ने क्या किया बेटा, ये सिल्वर फॉइल लिया, and this silver foil, you just put the silver foil like this and do a taping on 3 sides. By just taping on 3 sides, advantage is the outside air will not be going inside, but whatever inside air is there, that inside air may be coming out. So this silver foil is actually acting as a valve. The silver foil is actually acting as a valve. This is called as a valvular dressing. By putting this, outside air is not going inside, but whatever air has gone inside, that is coming out from this side. Okay, so there is a 3-sided taping what we are seeing. This is what we call as the sucking wound. Air is continuously getting sucked inside. Sucking wound or open pneumothorax. This is a communicating wound between the pleural cavity and the outside atmosphere. The treatment is a valvular dressing. With 3-sided taping. Valvular dressing with 3-sided taping. So that outside air cannot go inside, but the inside air is going outside. And once you have done this in emergency, then you can put the intercostal tube drainage with breathing exercise. Intercostal tube drainage with breathing exercise. Right. And the last thing in this chest trauma is something regarding flail chest. Now flail chest beta, flail chest is actually, if you just look at this image carefully, it is a consecutive multiple rib fracture. लगातार अगर मल्टीपल रिब फ्रैक्चर्स हैं, फॉर एग्जाम्पल द डेफिनेशन सेज 2 or more than 2 consecutive rib fractures at 2 or more than 2 sides. For example, beta, if you look at this picture, there's a fracture here, 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 there's a fracture here. So this is more than 2 consecutive rib fractures at 2 sides what we are seeing. And by definition, 2 or more than 2 consecutive rib fractures at 2 or more than 2 sides. What is the significance actually, beta? This fractured segment, this becomes isolated from rest of the chest wall and it starts showing paradoxical respiration. Kaisa respiration, beta? Paradoxical respiration. Now paradoxical means what? See, generally when you are breathing now, so air is going inside, lungs are expanding, the ribs are also moving out. But in a flail chest, inspiration, lungs are moving out, but this fractured rib, they are moving inside. Lungs are coming out, but the fractured ribs are going inside. So there is a high risk of lung injury in flail chest. That is why it is a serious emergency situation. And we have to prevent the injury to the lungs quickly. Right? Okay. So flail chest, beta, by definition, this is 2 or more than 2 consecutive rib fracture at 2 or more than 2 sides. This flail segment demonstrates paradoxical respiration. And in the treatment, apart from good analgesia which can be given by IV narcotics, maybe local anesthetics, maybe nerve blocks or epidural analgesia, we provide oxygen support and we can give positive pressure ventilation. That is how we can manage this flail chest situation. This is also a surgical emergency. This is also a surgical emergency. So beta, in chest trauma, the various emergency conditions what we talked about, we talked about tension pneumothorax, beta. This is a surgical emergency. Then we talked about a open pneumothorax. That is actually just like a tension pneumothorax, or you can say a sucking wound. Sucking wound because it is continuously sucking the air. Or we can say here flail chest. And cardiac tamponade. These are all emergency situations, beta, where the patient is going to lose his life in seconds or maybe just in very few minutes, right? So tension pneumothorax में हम क्या कर रहे थे बेटा? What we were doing in tension pneumothorax? We were putting a wide bore needle. Open pneumothorax, sucking wound of the chest, we were putting a valvular dressing. Flail chest, we are just trying to keep the fractured ribs away, maybe by positive pressure ventilation. In cardiac tamponade, beta, we were doing a pericardiocentesis. Pericardiocentesis, right? So I hope you have got the whole crisp idea about this chest trauma. And please, beta ji, as we saw, there were 2 questions related to chest trauma on 4th of June. There will definitely be 1 question on 17th of December at least. So please see as many x-rays as possible. Please do exercise for this chest trauma nicely. If you have any doubts or anything, please do write to me today late evening, maybe around 7:30, 8 o'clock, when we would be closing with the class. Right here, what we'll do is we'll take a break here, beta, and we'll take a 20 minutes break, and we'll be back at 5:25 p.m. We'll be back at 5:25 p.m. See you. God bless. Let me just also quickly scroll the WhatsApp if there is something which is troubling you. There are dual voice in the live video. Oh my God. I said elbow joint. No, 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 beta. It is the wrist joint. I am so sorry if I mentioned elbow joint. Very good, beta. So I think there are good queries. That means you're listening carefully. So I think I'll respond to all your queries once we complete the session for today. Right. Thank you very much. Let's be back at 5:25. Bye-bye. Take care.
कैसे हो बच्चों? How are you? कैसा चल रहा है? I hope you must be doing good.
सर्जरी समझ आ रही है?
The point is पैथो तुम्हें समझ में आया ना? हेमैट बेटा रिवाइज जरूर कर लेना उसको. It is very important to revise that. And good luck.
Yeah, and there are a lot of pathology concepts which are integrated with surgery, which I'll be using at so many places, right?
So do good. God bless. ठीक है सर.
Right, beta. So I hope you would have had something, maybe some tea, coffee, or something. Right. Just give me a moment. Right, beta. So let me just take a few doubts here, few queries, so that in the end it is not too much. The last 5 digits 59226, beta. Please do mention your name and university. You are having a doubt that in anterior cranial fossa fracture both epistaxis and CSF rhinorrhea is present. No. Epistaxis is just a nasal bleed. CSF rhinorrhea is leakage of brain fluid CSF from the nose. How to differentiate it if both are mixed? Yes, there is a halo sign or a target sign what we see in CSF rhinorrhea. If you just take that fluid on a tissue paper, you will see the blood in the center and you will see the translucent fluid all around, which we call as target sign or a halo sign. Confirmatory test is you can test for a protein that is beta 2 transferrin. If that is present in the fluid, that means it is CSF. Vijay from Bogomolets, most common hematoma is subdural and most common hemorrhage is subarachnoid hemorrhage. Yes, you are correct. The last 5 digits 38723. Please do mention your name and university. There are two choices: 30-year head injury who is unconscious and 30-year conscious with profuse bleeding. Whom we segregate first on the basis of severity. Profuse bleeding is definitely the first thing to be segregated. Navyu from Northern State, can you please explain once more why bradycardia and hypertension is seen in head injury? Navyu, basically, whenever the intracranial pressure is high, if there is somebody who is putting pressure on the brain stem, then yes, the heart rate goes down and the blood pressure goes up. Sohail Sheikh from Tambov, a very warm welcome from Tambov. Sohail, I hope the Tambov students have come back to India from Tambov. You completed a MBBS in 2019, but still... Okay, so you want to join MIST online live. Okay. Right, so this was a query related to admission. Aditya from Orenburg, yes, it is wrist joint beta, which is used in percussion. It is not the elbow joint. I'm really sorry for my mistake. Chetan from Karasin, you said when sharp trauma is occurred, we shouldn't remove the object out. In case someone removes it, can we put the object back or no one on the roadside? No, 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 no. If somebody has already taken the foreign body out, then you don't have to put it back inside, beta. The last 5 digits 36464. Beta, please do mention your name and university. In tension pneumothorax, when you insert the needle, then why the air come out? No, beta, in tension pneumothorax, the inside pressure is more and the outside pressure is less, because this is a massive pneumothorax. Huge amount of air has gone inside, so the inside pressure becomes positive. Dhrutiman from Uzgrowth, what's the difference in tension pneumothorax and sucking wound? Sucking wound is a penetrating trauma where there is a wound in the chest wall because of which the outside air is continuously getting sucked inside. Tension pneumothorax can be because of the sucking wound, or sometimes when there is spontaneous pneumothorax, like suppose somebody is having emphysema and suppose there are emphysematous bulla in the lung which can rupture. So huge amount of air can leak inside the pleural cavity, and that, if it is a massive air collection putting pressure on the opposite lung, that is also a case of tension pneumothorax. Akash from New Vision University, Georgia. Cardiac tamponade, Akash. It is a fluid collection around the heart. If we are talking about trauma, suppose somebody has hit a knife into the chest and there is injury to the heart, then the heart blood will leak outside the heart and will get collected in the pericardial cavity. So huge amount of blood getting collected in the pericardial cavity. This is going to put pressure on the heart and the heart will not be allowed to work. So the heart is not able to contract properly and the patient can die. Right? There is hypotension, there is raised jugular venous pressure and muffled heart sound. This is what is cardiac tamponade, and this requires immediate needle into the pericardial cavity to drain that blood. That is immediate needle pericardiocentesis. Firdosh from Uzgrowth, please explain one more time cardiac. I hope cardiac tamponade you got it, Firdosh. Tension pneumothorax is a massive air collection which is putting pressure not only on one side lung but also on the opposite lung. There is a mediastinal shift seen in tension pneumothorax, and since there is huge amount of air collection where both the lungs are getting collapsed, on percussion you will hear a hyperresonant note, and on auscultation the breath sounds will be markedly diminished. KNMU Anish, can you explain hypertension and muffled heart sound? I hope you got it, beta. Paradoxical respiration is the opposite movement of the ribs. During inspiration, Anish, the lungs move out, and in a normal person, the ribs also move out. But in flail chest, during inspiration, when the lungs move out, the rib cage goes inside. And during expiration, when the lung goes inside, the rib move outside. That is opposite movement of the ribs during breathing. That is what is paradoxical respiration. Last day of, may I know your university, beta? Flail chest, the first step needed to be taken is surgical intervention, or there is particular like seen in tension pneumothorax or open pneumothorax? It is a surgical intervention. Last 5 digits 60936. Please do mention your name and university, beta. Intercostal tube drain name. It is a simple intercostal tube drain. We can use various type of catheters which come by different names. Just a tube catheter, maybe a Malicot catheter can be used. In French size, it is 28 to 32 French. 3 French is equal to 1 millimeter, and 28 to 32 means divided by 3. So it is approximately 9.3 millimeters to 10.3 millimeters in diameter. DD is differential diagnosis. Edentulous is if the patient does not have the teeth either the patient has lost the teeth in the accident or the patient was elderly who has lost the teeth spontaneously. The last 5 digits 36794. Please do mention your name and university beta. Blunt, very good evening. Blunt trauma case, both open and tension pneumothorax. No, tension pneumothorax can be because of open pneumothorax also. I think you got the answer in the above explanation. Ragul from Venezia. Tension and open pneumothorax. Open pneumothorax is an open wound in the thorax which can lead to tension pneumothorax. Thank you, beta. Thank you. Neeti, please mention your university, beta. Open pneumothorax is when there is an open wound in the thorax, and closed would be just like what I explained in spontaneous pneumothorax, maybe because of emphysematous bulla getting ruptured, huge amount of air getting leaked into the pleural cavity, putting pressure not only on the ipsilateral lung, but also on the opposite lung as well. Seva from Karasin. If the negative pressure inside lungs can draw in atmospheric air, why it is not drawing the water inside from underwater seal? Is it because the negative pressure of the lung is less to draw in water? Yes, the negative pressure of the lung is less to draw in the water pressure. Danush from Volgograd. Yes, beta, you have a question with reference to hemothorax. Why do we perform drainage in fifth intercostal space? Yes, that is what I was, this is something which is applicable for all the students, beta, that if we are talking about hemothorax or any fluid collection, then generally the fluid settles down. So whatever is written in our textbooks, including Bailey and Love, they say that we should put the tube in the lower space, maybe the 7th or 8th intercostal space, and maybe towards the posterior axillary line. But generally we are putting that in mid-axillary line according to the standard textbooks. If it is a case of pneumothorax, air rises up, so we should put the tube in the second intercostal space. But according to ATLS guidelines, whether it is a pneumothorax or hemothorax, we are putting the tube in the 4th, 5th intercostal space. That is the safest area. That is called as the triangle of safety. The only thing what ATLS says is, if there is more amount of pneumothorax, the inner end of the tube is directed upwards. If it is hemothorax, the inner end of the tube is directed downwards. So for all trauma questions, 17th of December, we are going to follow ATLS guidelines. Manmohan, please do mention your university, beta. Do we need to know anything about SH in detail? Yes, that will be done in forensic medicine, beta. I hope paradoxical respiration, you would have got it. Snehil Jyoti from Jonelta School of Medicine, Philippines. What's the difference between a sucking wound? Sucking wound is a continuous sucking of air from outside to inside, most likely because of a penetrating trauma when there is an open wound. While tension pneumothorax can result after a sucking wound, or it can also be seen in closed pneumothorax when emphysematous bulla in the lung ruptures. I think there are a lot of messages. Last 5 days 74664. If a patient is having hemopneumothorax, means can we make double puncture? And there is no need, beta. Just one tube is enough. And now I'll be taking all the queries after the class, beta. Right? I hope you can understand. There's so many students who would be waiting and who would not be having any queries. So let me take all the queries later on. Right. So now moving from this chest into the abdominal area, and there we'll be talking about the abdominal trauma. In abdominal trauma, again, beta, there can be either a blunt abdominal trauma or a penetrating abdominal trauma, or maybe a seat belt abdominal trauma. Or sometimes there can be bomb blast explosions which can lead to this trauma type of situation. Now, blunt trauma, beta, let us just understand, let us just try to imagine, suppose there was a main road and you were standing on the side of the main road. There were vehicles which were moving at a fast pace. Suddenly you saw that a person was crossing the road and he was hit by that high speeding car. And because of that, he suffered injuries all over the abdomen, maybe over the liver, spleen, and so on. So that is what is a blunt trauma. We should know, beta, that inside our abdomen, God has given us 3 solid organs: liver, spleen, and kidney. They are full of blood. So majority of the times the injuries are seen to these solid organs. Blunt abdominal trauma, it is the spleen which is getting injured most often. Second most commonly, it is the liver. Penetrating abdominal trauma, suppose somebody has hit a knife in the abdomen, then most often it is the liver which gets injured. And second most commonly, it is the small intestine. Small intestine, if you look at your GI tract, beta, God has given you mouth, then there is a pharynx, then there is esophagus, then the stomach, then the duodenum, then the jejunum, ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. Small intestine is duodenum, jejunum, and ileum. The length of the small intestine, beta G, is 6 meters. कितनी होती है? 6 meters. That is 600 centimeters. And you can just imagine, beta, the 6 meter is lying inside your abdomen. So whenever somebody hits a knife into our abdomen, the 6 meter long small intestine can come in contact with that knife and suffer from injury. Seat belt abdominal traumas, generally it is injury to the mesentery. Mesentery is a fan-shaped organ which is having the blood vessels which are supplying blood to the intestine. So if mesentery is injured, which is most often near the duodenojejunal flexure where the injury occurs, if blood vessels supplying blood to the intestine, they are injured, then obviously it will lead to ischemia of the intestine. That is gut ischemia. Bomb blast injuries. Now, if there is a bomb blast, then what is going to happen? There will be injuries related to shrapnels which come out of the bomb, and these sharp objects may be hitting people here and there. And second, in bomb blast, there is huge amount of energy which comes out under high pressure. Now just imagine, beta, that suppose you are sitting in a class, right? And there is a bomb blast in the class. What will happen? Suppose a person is standing near that bomb versus a person who is lying on the floor. So since huge amount of energy is liberated up, so a person who is standing will have more chances to suffer from injury. And in this high explosive injuries, it is usually the air-filled cavities which are getting injured. Air-filled cavities which are getting injured. So if we take a look from top to bottom, the air-filled cavities are eardrum, trachea, lungs, and intestine. So this is actually the sequence of organs which are getting injured in bomb blast injuries. Right. Now there is a controversy with the forensic medicine. In forensic, generally they mention that lungs are the most common organs which are getting injured. But we know that if we look at the sequence, the topmost is the eardrum. So there would be high chances of damage to the eardrum. To sort this controversy, If they ask you most common structure injured in bomb blast, it is eardrum. If they ask you most common organ injured in bomb blast, then the answer will be lungs. So let us first see what all we are supposed to write here, beta. Blunt abdominal trauma most common it is the liver. Sorry, most common it is the spleen. And second most common it is the liver. While penetrating abdominal trauma, most commonly it is the liver. And second most common it is the small intestine. In seatbelt abdominal trauma, that is whiplash injury, most commonly it is the mesentery, which is carrying the blood vessels which are supplying blood to the intestine. So if they are injured, there will be ischemia of the intestine, that is called as gut ischemia. Gut ischemia. In bomb blast injuries, there may be injuries related to shrapnel or there may be explosive energy injuries. Most commonly, the air-filled cavities are injured in a sequence: eardrum, then trachea, then lungs, and then intestine. If they ask you most common structure getting injured in bomb blast, then you can mark the answer as eardrum. If they ask you most common organ getting injured in bomb blast, then you can mark the answer as lungs. Right. So I hope you have written it, beta. Now let us try to imagine and understand that how blunt abdominal trauma and penetrating abdominal trauma patients present to us, and how as a doctor we are supposed to approach these patients. So first let us just try to understand. This what you are seeing, beta, this is one of the most important tables, and I personally believe that we are going to get one question from this particular table on 17th of December. So before that, let us try to understand what this table has actually mentioned. So beta, first let me explain this in Hindi and then I'll repeat the explanation in English because I feel this is really going to be very important. Imagine करते बेटा एक कहानी कि मान लीजिए हम सड़क पे खड़े हुए थे, सड़क के किनारे, और अचानक से हमने देखा कि एक बंदा जो सड़क क्रॉस कर रहा था उसके ऊपर से एक तेजी से कार आई और वो कार का पहिया जो था उसके पेट के ऊपर से चढ़ के निकल गया। अब ऐसे में क्या होगा? ये पेट को ब्लंट ट्रॉमा हुआ। पेट के अंदर लिवर, स्प्लीन, किडनी। अच्छा बेटा, कितने लिवर होते हैं अपने पास? एक लिवर होता है। लिवर राइट साइड में होता है कि लेफ्ट साइड में होता है? राइट साइड में होता है। और स्प्लीन कितनी होती है बेटा? एक होती है लेफ्ट साइड पे। और किडनी कितनी होती है बेटा? दो होती हैं, है ना, दोनों लंबर रीजन में होती हैं, राइट, यहाँ पे। ओके, नाउ सपोज करो कि वो गाड़ी का पहिया पेट के ऊपर चढ़ गया, लिवर में इंजरी हुई, स्प्लीन में इंजरी हुई, थोड़ा ब्लीड हुआ, और अब इस पेशेंट में क्या हो सकता है? वैसे तो अगर लिवर स्प्लीन उड़ा है तो खूब सारी ब्लीडिंग होगी और ये ब्लड सारा पेरिटोनियल कैविटी में आएगा और खूब सारी ब्लीडिंग की वजह से पेशेंट ऐसे कोलैप्स हो जाएगा, है ना। लेकिन कभी कभी ऐसा भी होता है बेटा कि गाड़ी का पहिया पेट के ऊपर से निकला और ये पेशेंट एकदम से उठ के खड़ा हो गया और गाड़ी को देख रहा है, अबे क्या करता है, ऐसे पेट के ऊपर से निकाल के ले जाते हैं क्या? नाउ यू आर वॉचिंग ऑन द रोड साइड, आप रोड के किनारे खड़े होकर देख रहे हो कि ये क्या हुआ, पेट के ऊपर से गाड़ी का पहिया निकल गया और बंदा खड़ा हो गया, ऐसा कैसे? वो हिंदी में एक कहावत है बेटा जाको राखे साइया मार सके ना कोई, है ना। गाड़ी का पहिया पेट के ऊपर से निकला, इंजरी हुई होगी स्प्लीन में या लिवर में, और ये ब्लड जो था ये इमीडिएटली वहां पे क्लॉट बन गया। अभी अगर क्लॉट बन गया बेटा तो ये क्लॉट क्या करेगा, प्रेशर डालेगा, और प्रेशर की वजह से जो ब्लीडिंग हो रही थी उसको रोक देगा। मतलब इंजरी तो हुई, लेकिन जो ब्लड निकला वो फटाक से क्लॉट हो गया। वो ऊपर वाला है ना, उसने ब्लड को क्लॉट कर दिया, और क्लॉट की वजह से प्रेशर लग गया, और प्रेशर की वजह से वो ब्लीड बंद हो गई, और पेशेंट ऐसे उठ के खड़ा हो गया और गाड़ी वाले को देख रहा है कि भाई क्या करता तू। लेट मी नाउ रिपीट दिस एक्सप्लेनेशन इन इंग्लिश. We are just trying to understand what can be the different situations in blunt abdominal trauma. For example, suppose you are standing on the roadside and you see that a person who was crossing the road suddenly is hit by a speeding car and the car tire has run over the abdomen. This might have caused injury to the liver or to the spleen, right? Now, when there is injury to these solid organs, ideally there should be massive bleed. And because of this massive bleed, patient should be collapsed like this. But rarely we can find that even after this injury, the patient suddenly stands up and starts staring at that car and starts abusing that driver, that what the hell you have done? You have taken the car over my abdomen. Now, how this we can correlate scientifically, how this is possible? We know God has all the rights, right? So man proposes, God disposes. Now, there is a scientific evidence here. There might be injury to the liver or to the spleen. Bleeding has started, but soon the blood has clotted around the injury. And this blood clot is putting pressure on the bleeding vessel. And this is a direct pressure by the clot over the bleeding vessel, and the bleeding can stop. And if the bleeding stops, the patient is stable and the patient stands and starts staring at the driver, right? So this is a hemodynamically stable situation. Now, what should be done in this situation? Let me explain this in Hindi first and then in English. अगर मान लीजिए आप सड़क के किनारे खड़े हैं और आप देख रहे हैं कि अरे बाप रे, ये तो ऐसे खड़ा हो गया है। अब वो मान लीजिए वो जो बंदा है वो आपकी तरफ आ रहा है, उसे कहीं से पता लग गया कि यार ये डॉक्टर लोग हैं, वो अब आपकी तरफ आ रहा है। अब आप क्या करोगे? ऑब्वियसली अगर वो ठीक ठाक है तो आइडियली तो सब ठीक ही होना चाहिए। अब वो आपसे कह रहा है जी भैया मेरे को ऑटो करा दो या रिक्शा करा दो या ड्राइवर टैक्सी करा दो, मेरे को घर छोड़ दो। आपको चूंकि ये साइंस पता है कि भाई ये जो आप खड़े हुए हो ना अभी कार का पहिया निकलने के बाद भी, ये इसलिए खड़े हो भाई साहब क्योंकि वो क्लॉट बैठा हुआ अंदर, उसने रोकी हुई है अभी आपकी कहानी। जहाँ ये क्लॉट डिसलॉज हुआ वहीं ब्लीडिंग फिर चालू हो जाएगी और फिर चांसेस हैं कि फिर गड़बड़ हो जाए मामला। तो आप चाहते हो कि भैया ये इस इंसान को आप अस्पताल ले जाओ, और अस्पताल में जब ये पेशेंट जो है डॉक्टर साहब के पास पहुंचता है इमरजेंसी में, अब इमरजेंसी में स्टूल पे बैठ गया ये डॉक्टर के सामने और डॉक्टर आपको कहानी बता रहा है, डॉक्टर साहब देखो ऐसा ऐसा हुआ, एक गाड़ी वाला था ऐसे पेट के ऊपर से निकाल के ले गया। हैं? पेट के ऊपर से निकाल के ले गया? अच्छा, फिर कुछ नहीं जी। आप क्या करना है? पेशेंट तो स्टेबल है, एमसीक्यू वाले पूछ सकते हैं कि भैया ये जो पेशेंट स्टूल पे बैठा हुआ है इसका क्या करना है, क्या पेट खोलेंगे या नहीं खोलेंगे? अरे भाई जब स्टेबल है तो काय को खोलेंगे? एक काम करते हैं, फटाक से एक फोकस्ड अल्ट्रासाउंड कर लेते हैं। फोकस्ड अल्ट्रासाउंड, उसमें क्या करेंगे, उसमें हम एपिगैस्ट्रियम में प्रोब रख के हार्ट के अराउंड देख लेंगे, राइट हाइपोकॉन्ड्रियम में प्रोब रख के लिवर और राइट किडनी देख लेंगे, लेफ्ट हाइपोकॉन्ड्रियम में प्रोब रख के स्प्लीन लेफ्ट किडनी देख लेंगे, और एक पेल्विस में प्रोब रख के देख लेंगे कि भैया कोई ब्लीडिंग है तो जिससे पेल्विस में कोई ब्लड तो नहीं आ रहा है। तो फटाफट से ये फोकस्ड अल्ट्रासाउंड कर लेंगे। और अगर फोकस्ड अल्ट्रासाउंड में लगता है कि यार थोड़ी बहुत इंजरी तो दिख रही है लेकिन ठीक से नहीं पता चल रहा क्या कहानी है, तो बेस्ट है सीईसीटी कर लो। सीईसीटी, कॉन्ट्रास्ट इन्हेंस सीटी स्कैन। सीटी स्कैन में सारे ये जो सॉलिड ऑर्गन्स है ना, लिवर किडनी स्प्लीन, इनका पेरेन्काइमा बढ़िया दिख जाता है एकदम। और फिर सीटी में दिख गया कि हाँ भैया थोड़ी बहुत इंजरी है लेकिन इतनी ज़्यादा नहीं है कि अपने को इसको ऑपरेट करना पड़े, तो अपन इसको 24 घंटे के लिए ऑब्जर्वेशन में रख लो कि भैया कोई ब्लीडिंग ना हो जाए, ठीक है, यानी कि ट्रीटमेंट इसका नॉन ऑपरेटिव हो गया। नाउ आई रिपीट दिस इन इंग्लिश, हाउ यू हैव टू अप्रोच दीज सिचुएशंस। What we saw was कि after that injury, the patient stood up and he looked to be stable. We should not allow this patient to go home because we know the signs that why this patient is stable, because there is a clot and this clot is putting pressure on the bleeding vessel. So as of now, the bleeding is controlled. But suppose he goes back to home and starts playing cricket or something or whatever, then this clot can dislodge and bleeding can restart and the patient can die because of that bleed. So we cannot leave this patient like this. We should take him to the hospital. Now in the hospital, since patient is stable, patient might be sitting on the stool right in front of the doctor and telling him the history. The doctor, see what happened actually was there was a car and that car tire ran over my abdomen and so and so. And now what should be done? So now you are looking at the patient is stable. What you feel is, okay, if the patient is telling the true story, then let us quickly do a focused ultrasound. Focused ultrasound means let us look at the solid organs, let us look at the heart. So let us keep the probe in the epigastrium for the heart, right hypochondrium for the liver and right kidney, left hypochondrium for the spleen and left kidney, and a probe in the pelvis. If there is any bleed in the peritoneal cavity, pelvis is the biggest gutter. So any fluid in the peritoneal cavity will be leaking into the pelvis. So we can focus on these areas and come to know whether there is any injury or not. If we come to know that, okay, there is some mild injury we are feeling maybe in the liver or the spleen, then best investigation to know the extent of injury here would be a CECT, contrast enhanced CT scan. And generally, the CECT results show that, okay, this is the injury, but the injury is not so much that we have to do some operative intervention in these patients. This is how we are managing the hemodynamically stable patient. The focused ultrasound, what we did is called as FAST, Focused Assessment by Sonography in Trauma. Now, we are also extending this abdominal screening to the thoracic screening. This is called as extended FAST or eFAST, where apart from these four things, we also keep the ultrasound probe in the right thoracic cavity and the left thoracic cavity to look for any pleural collection or for any hemothorax also, right? So a stable patient story is very clear in front of us. Blunt abdominal trauma, patient stable, admission in the hospital for 24 to 48 hours, do a FAST, do a CECT. Usually treatment is non-operative. I hope this is absolutely clear in your minds, beta. बात समझ आई ये वाली? Very good. अच्छा, now we go to the actual scenario. Again, first I'll explain in Hindi, then I'll repeat this in English. अभी मान लो कि अपन सड़क किनारे खड़े हैं, एक्सीडेंट हुआ, और एक्सीडेंट होते ही क्या हुआ, वो जो गाड़ी का पहिया था उसने लिवर स्प्लीन फोड़ा और खूब सारी ब्लीड चालू हो गई, और खूब सारी ब्लीड चालू हो गई तो क्या होगा बेटा, वो जो खून की पाइपलाइन अंदर फट गई है तो खूब सारा ब्लीड निकले जा रहा है, हार्ट रेट तुरंत भाग रही होगी, और अगर बहुत ज्यादा ब्लीड हो रहा है तो बीपी भी फॉल कर रहा होगा, है ना। ब्रेन को भी हो सकता है ऑक्सीजन की सप्लाई कम हो रही हो और पेशेंट अनकॉन्शियस ऐसे होता जा रहा हो, राइट। सो पेशेंट इज ऐसे कोलैप्स्ड। तो अपने को सबसे पहले जो भी पहला 3 व्हीलर या 4 व्हीलर मिल जाए, 2 व्हीलर नहीं बेटा, 3 व्हीलर या 4 व्हीलर, उसमें डाला फटाफट और फटाफट अस्पताल ले गए। अस्पताल में जैसे इमरजेंसी में पहुंचेंगे वहां डॉक्टर जैसे ही देखेगा, अरे भाई साहब इसकी तो पल्स नहीं है, रेडियल नहीं फील हो रही, ब्रेकियल नहीं फील हो रही, कैरोटिड, हाँ कैरोटिड मिल गई, यानी कि भाई साहब थोड़ी सप्लाई तो है, 60 मिलीमीटर तो प्रेशर है ही है, यानी कि अपन बचा सकते हैं इसको। वो क्या रहा है, अंदर बिल्कुल पाइपलाइन फटी हुई है और उसकी वजह से ब्लीड हो रहा है और पेशेंट बिल्कुल जाने की हालत में, फटाफट से वही अपन एबीसी करेंगे। एयरवे अगर ठीक ठाक है तो कुछ जरूरत नहीं इधर करने की, लंग्स में कोई दिक्कत नहीं है तो यहाँ भी कुछ जरूरत नहीं है। अगर सिर्फ पाइपलाइन फटी है जिसकी वजह से खून निकले जा रहा है तो अपन उस पाइपलाइन में दबा के पहले तो फ्लूइड मारेंगे जिससे कि कुछ तो प्रेशर जनरेट हो, थोड़ी बहुत ऑक्सीजन तो जाए भैया इधर उधर। तो फटाफट से वही नॉर्मल सलाइन लगा दिया, वही 1 लीटर नॉर्मल सलाइन 1 घंटे में फटाफट से फ्लूइड चैलेंज दे दिया, लगे हाथ ब्लड भी चढ़ा दिया, प्लेटलेट भी चढ़ा दी, FFP भी चढ़ा दी, ट्रेनेक्सेमिक एसिड भी चढ़ा दिया, चढ़ाए जा रहे हैं। लेकिन अंदर अगर पानी की जो खून की पाइपलाइन ज़्यादा फटी है तो जो भी चढ़ा रहे हैं वो लीक भी कर रहा होगा। यानी कि अगर इतना सब कुछ चढ़ाने के बाद भी पेशेंट की पल्स कम नहीं हो रही और BP बढ़ नहीं रहा है, इसका मतलब भैया अगर अभी भी हाथ पे हाथ रख के बैठे रहे और वो अंदर का जो पाइपलाइन फटी है उसको फटी रहने दिया और लीक करने दिया तो पेशेंट बहुत जल्दी मर जाएगा। अपने को इसकी ज़िंदगी बचानी है। पानी पुनी चढ़ाने से, ब्लड चढ़ाने से जान नहीं बच रही है। फटाफट बिना देर के तुरंत ऑपरेशन थिएटर में ले जाओ। हाँ, जब अपन ये पानी वानी चढ़ा रहे थे, ब्लड चढ़ा रहे थे, इतने में ही अगर मान लो इमरजेंसी में अल्ट्रासाउंड की मशीन है और रेडियोलॉजिस्ट है, फटाक से रेडियोलॉजिस्ट को बुलाते, भाई जरा फटाफट आके देखियो यार कहाँ पे ज़्यादा ब्लीड हो रही है। तो रेडियोलॉजिस्ट आके फटाफट से प्रोविपिगेस्ट्रियम में राइट हाइपोकॉन्ड्रियम, लेफ्ट हाइपोकॉन्ड्रियम, पेल्विस वगैरह में रखता है, थोरेसिक कैविटी में रखता है और बता देता है कि हाँ भैया मेरे को लग रहा है इस तरफ ज़्यादा मामला खराब है। और आप पेशेंट को फिर फटाफट से, जरूरी नहीं है कि अपन फास्ट करें, पेशेंट की ज़िंदगी बचाना ज़्यादा ज़रूरी है, ठीक है ना। वो तो ज़िंदगी बचाने के लिए जो अपन IV फ्लूइड ब्लड वगैरह चढ़ा रहे हैं उस समय पे अगर अपन फास्ट कर सकते हैं तो बहुत अच्छी बात है। और फिर पेशेंट को तुरंत ले जाओ ऑपरेशन थिएटर में और यहाँ ऐसे मिड लाइन से खोल डालो और खोल के फटाफट जहाँ से पाइपलाइन फटी है वहाँ पे प्रेशर लगा दो। जैसे ही उस फटी हुई पाइपलाइन पे प्रेशर लगेगा ब्लीडिंग बंद हो जाएगी। और फिर एनेस्थेटिस्ट को बोलते हैं आप चढ़ा तू फटाफट, लगा IV फ्लूइड, लगा नॉर्मल सलाइन दबा के चढ़ाते जा, क्योंकि मैंने ये पाइपलाइन जो फटी है उसको रोक लिया है। अब जो भी तू चढ़ाएगा वो पेशेंट के वैस्कुलर कंपार्टमेंट में रहेगा और उससे पेशेंट का BP बढ़ जाएगा, उससे पेशेंट का हार्ट रेट कम हो जाएगा। और फिर पहले वो फ्लूइड चढ़ा रहा है, ब्लड चढ़ा रहा है, उससे पेशेंट की अपन जिंदगी बचा सकते हैं। राइट, नाउ आई रिपीट दिस इन इंग्लिश। Let us just imagine the actual scenario कि you are standing at the roadside and there is an accident right in front of you. There is a injury supposed to the liver and the spleen and there is massive bleeding going on inside the peritoneal cavity. As soon as there is massive bleeding going on, the heart initially is trying to pump faster and faster, that is tachycardia. But if there is massive amount of bleeding going on, even the blood pressure would be falling down, right? And because the blood pressure is falling down, maybe the blood supply to the brain is not proper and the patient might be losing consciousness also. Now, this is the patient who is lying on the road. There are so many people gathered around. Immediately what we have to do is take a 3-wheeler or a 4-wheeler, not a 2-wheeler, 3-wheeler, 4-wheeler, and rush this patient to the hospital in the emergency. In the emergency, as soon as the patient is in front of the emergency duty doctor, then first and foremost thing of the duty doctor is to save the life of this patient. If there is a blood pipeline which is leaking blood, right, so the heart rate is moving fast, maybe the blood pressure has gone so much down that his peripheral pulses may not be palpable, radial is not palpable, brachial not palpable, but carotid, yes, it is palpable, so pressure is 60, we can save the life of this patient. Why this patient's pulse is going up and the BP is going down? Because there is massive bleeding. So we immediately start pumping in that normal saline, right? Just to increase the intravascular volume so that some pressure can be generated inside the system. We can also pump in that blood, platelets, fresh frozen plasma, tranexamic acid, everything. But by chance, if suppose there is a massive leak inside, if there is massive leak from that blood pipeline, then even after pumping all this story, the fluid is leaking out. It is not remaining inside the circulation. It is not going to every cell of the body. The patient may die very quickly. So, in order to save the life of this patient, we have to stop the bleed. And this can be possible if you directly take this patient in the operation theater, open the abdomen by a midline incision, apply the direct pressure on the bleeding site, and then you ask the anesthetist to pump in fluids or blood, platelets, clotting factors, etc. Herein, when you were doing that resuscitation in the emergency, when you are pumping in IV fluids, blood and everything, and you were trying to revive the patient in emergency, if the ultrasound machine is available in the emergency, if the radiologist is available in the hospital, you quickly call that radiologist and ask the radiologist to do a fast quickly so that he can give us an idea that which side the injury is more, right? There is no time to get a CECT done. हमारे पास इतना वक्त नहीं है कि हम इस पेशेंट को CT करने के लिए CT के कमरे में भेज दें. If by chance you send this unstable patient for CT scan, there is massive bleeding inside. Bleeding is going on. The patient will die in the CT room. So there is no point in getting a CT done in an unstable patient. I hope this is absolutely clear and nicely understood. Right? Please do not do a CCT in an unstable patient. Okay? Right. Now let's see what all is written here. Right, so blunt abdominal trauma, patient is hemodynamically stable or unstable. Stable beta, we know if the shock index is less than 1. Unstable is more than 1. So in a stable patient beta, we are admitting the patient for observation. First what we can do here is fast. But the best what we can do here is a CECT. Based on the results of these investigations, we can decide what has to be done. Usually non-operative, or you can say usually conservative treatment. Usually non-operative, or you can say conservative treatment. While if the patient is hemodynamically unstable, if he is bleeding, then circulatory management is going to be very, very important. In this, when you are doing the basic resuscitation, you can go ahead with doing a fast. This DPL is not done nowadays. DPL, this is not Delhi Premier League or Doctors Premier League or Indian Premier League. It is actually diagnostic peritoneal lavage. This has become obsolete. Nowadays, we are not doing this DPL. One line is mentioned later, so we'll discuss this later. So in emergency, in an unstable patient who is dying, you are pumping in IV fluids, blood, fresh frozen plasma and all. You can quickly do a fast, no role of CECT. Immediately take the patient for laparotomy, and usually we open the abdomen by a midline incision. Why midline incision? Because midline incision is the fastest access to the peritoneal cavity. Fastest access to the peritoneal cavity. This is what is a midline incision. If you are cutting the structures in the midline beta, you have to cut the skin, subcutaneous tissue, linea alba. If by chance you are making an incision in the paramedian region, suppose you are making an incision in the paramedian region, then you have to first cut the skin, subcutaneous tissue, anterior rectus sheath, rectus muscle, posterior rectus sheath, and the peritoneum. It is taking more time in speaking out these different layers. So definitely it is going to take more time in cutting all these layers. But in the center, skin, subcutaneous tissue, linea alba, and directly there is peritoneum. Right? So paramedian क्यों नहीं देते? क्योंकि स्ट्रक्चर्स ज़्यादा है. बोलने में इन स्ट्रक्चर्स को ज़्यादा टाइम लग रहा है, तो खोलने में तो ज़्यादा टाइम लगता ही है. Right. Now, as soon as you have opened the abdomen, many times you see huge amount of bleeding from the liver, and you are not able to understand from which part of the liver the bleeding is going on. To stop these major liver bleeds, we can just put our thumb and index finger in the foramen of Winslow near the stomach inside, and we just put pressure in the hepatoduodenal ligament where portal vein and hepatic artery are going. Like instead of thumb and index finger, you can even use a clamp, and you can just put this clamp in the hepatoduodenal ligament. In this hepatoduodenal ligament, there is a portal vein going into the liver, there is a hepatic artery going into the liver. You know 80% of the supply to the liver is by the portal vein and 20% by the hepatic artery. So if you have clamped these vessels, blood supply to the liver is stopped. So whatever bleeding was taking place, that stops. And now you can gradually release this clamp and see from where the bleeding is taking place in the liver, and then you can control the liver bleeds accordingly. This maneuver where we are clamping or just pressing the portal vein and hepatic artery, this is called as a Pringles maneuver. Pringles maneuver. Pringles maneuver. First bit of what we were talking about, this is a focused assessment by sonography in trauma. First probe is put in the epigastrium, where we look for any pericardial fluid. Second bit, we put in the right hypochondrium, this RHC. This is right hypochondrium. Here we assess the liver and right kidney. Third, in the left hypochondrium beta, where we assess the spleen and the left kidney. And fourth, in the pelvis for any free fluid. Any free fluid in the peritoneal cavity. Any free fluid in the peritoneal cavity. E-fast beta. E-fast is extended fast, where we are not only taking care of abdomen, we are not only looking in the abdomen, but we are actually looking in the thorax also. So we can keep the ultrasound probe in the right pleural cavity and the left pleural cavity for any pleural collection. Right. I would like to show you beta that how do we read this fast quickly. Right. This is a focused ultrasound. Just look at the screen beta. These are the 4 areas what we are going to screen. Herein I hope we all are able to understand this what we are seeing. This is the heart shadow, and as you can see the 4 chambers of the heart here nicely. This area would be the pericardial cavity, right? Now, if there is any injury to the heart, the blood would have been leaking into this area, and the blood would be getting collected around the heart, something like cardiac tamponade. Whenever we are doing ultrasound beta, look at me on the screen, look at me. Yes. Whenever we are doing the ultrasound, fluid appear black on ultrasound. पानी अल्ट्रासाउंड में कैसा दिखाई देता है? काला दिखाई देता है. So when you are doing this ultrasound beta, you will find this black thing around the heart if there is injury to the heart or there is any collection of blood around the heart. Same way beta, if you look in the right hypochondrium. Now in the right hypochondrium beta, this structure what you're seeing, this is the right lobe of liver. This structure what you're seeing beta, this is the right kidney. This area which is between the liver and the right kidney, this is called as the hepatorenal pouch or Morrison's pouch. This is called as the hepatorenal or the Morrison's pouch. Hepatorenal or the Morrison's pouch. Hepatorenal or the Morrison's pouch. That is the space between the liver and the right kidney. Now, beta G, if there is any injury to the liver or to the right kidney, this blood may get collected in the hepatorenal pouch or the Morrison's pouch. And you may see this blood getting collected somewhat like this in this area. On ultrasound, fluid appears black. So you may see something like this on ultrasound. This is suggestive that there might be injury to the liver or to the right kidney, right? Now, if we take a look at the left hypochondrium beta J, in this left hypochondrium, this border what you are seeing beta, this is the spleen. And this what you are seeing, this is the left kidney. This area which is between the spleen and the left kidney, this area is called as the splenorenal pouch. This is called as the splenorenal pouch. Splenorenal pouch. Now, if there is any injury to the spleen or to the left kidney, then this blood would be coming here, and this blood would be getting collected in the splenorenal pouch. When you are doing the ultrasound beta, you will be seeing this black story between the spleen and left kidney, which will conclude that yes, there is injury to the spleen or the left kidney. And this what we are seeing, this is the fourth probe which we are putting in the pelvis. Like this is the female ultrasound beta. This border what you are seeing, this is the urinary bladder. Beta, can you tell me why this is black here? Why this area is black? Very good. Because this is bladder, so there will be urine inside the bladder, and this is fluid, so fluid appears black on ultrasound. This shadow what you're seeing beta, this is the uterine shadow, right? Now here this structure what you're seeing, this is the cervix, and this is the vagina, and here would be the rectal area beta. Okay, whether there is injury in the liver or maybe spleen, this blood is going to trickle and it is going to settle in the biggest gutter of the abdomen, that is the pelvis. This area beta what you are seeing here, this is called as the pouch of Douglas. इस area को बोलते हैं बेटा recto-uterine pouch or the pouch of Douglas. This is the recto-uterine pouch. Or the pouch of Douglas. This is the recto-uterine pouch or the pouch of Douglas. So if there is any bleed in the peritoneal cavity, this blood is going to trickle down, and you may find this blood in this recto-uterine pouch or the pouch of Douglas. Now, when you're doing the ultrasound beta, you know that fluid appears black. So you may find this black shadow in this pouch of Douglas. That is how we can make the inferences of this fast. Please remember beta, this is a focused assessment. This is not a routine ultrasound of the abdomen. This is being done just to assess the most important areas which can bleed, right? Which can lead to death of the patient. This is not the time when you ask the radiologist कि भैया अल्ट्रासाउंड तो कर ही रहे हो, जरा गॉल ब्लैडर में भी देख के बता दो पत्थर पड़े हैं का. This is not the time when you can request the radiologist to just look at the gallbladder and see whether stones are present inside the gallbladder or not. No, we are not concerned with all that stuff. We are just concerned with saving the life of the patient. So we are focusing on the solid organs in the abdomen which can bleed profusely. We are focused on the heart for the cardiac tamponade. We are focused on the thorax for any hemothoraxis. That is for what we are doing this focused sonography. DPL is a diagnostic peritoneal lavage. which is a sensitive investigation, but it is invasive and is not done nowadays. In DPL, beta, what we do, just a passing reference about this DPL. Isme, what we are doing, beta, suppose this is my umbilicus, right? Now, what we do is we make a small cut beneath the umbilicus. Make a small cut beneath the umbilicus. Pass a thin catheter or a thin feeding tube through this small opening in the skin. Take it right into the peritoneal cavity. So you have just put a thin catheter into the peritoneal cavity. You just push 100 ml of normal saline into this catheter so that this normal saline goes inside the peritoneal cavity. And now you can just shake the abdomen. Not like this, but you can ask the patient to turn on one side, then maybe turn on the other side. If there is any bleed in the peritoneal cavity, this fluid will get mixed with that blood. And now you aspirate. When you aspirate, if the returning fluid is bloody, that means there is bleeding inside the peritoneal cavity. But now, since we are having fast, so this DPL, it is invasive. Fast is able to tell us much more information than this DPL, so it is not being done nowadays. It has become obsolete, right? So I hope beta, this abdominal trauma, blunt abdominal trauma story is very clear. Depending on whether the patient is stable or the patient is unstable, our clinical approach changes, right? Okay, just give me a moment. Let me just have a look why this WhatsApp is ringing so much. Okay. Right. Now, beta, let us talk about penetrating abdominal trauma. Penetrating abdominal trauma means somebody has hit a knife into the abdomen. How we should react to this situation? If suppose you are standing on the roadside and there's a fight between two groups and you suddenly see that somebody has hit the knife has gone inside, and now that person who has been hit, he is coming towards you. See, somebody has put a knife here. Somebody has hit a knife in me. Would you like to take the knife out on the road? No. Right? We know the concept. There is a possibility the knife has gone inside, injured some vessel, blood has clotted around the knife and is acting as a pressure. And this pressure is preventing any further bleed. That is why this patient looks to be stable. As soon as we try to take the knife out, the clot will dislodge, bleeding will restart, and the patient can die. So we are not going to remove this foreign body on the road. We'll take this patient to the hospital, and there, under full precautions inside the operation theatre, the knife has to be removed. This is one story. Another story. Somebody hits a knife into the abdomen and takes the knife out. This patient is stable, and now this patient is coming towards you. See what the hell this person has done? He has put a knife here and has taken the knife out and ran away. Now what should be done in these situations? Should we open the abdomen or not? It depends. Patient is stable, so ideally there is no need to open the abdomen to save the life of this patient. Right? This is very clear. If the patient is stable, that means there is no major vascular injury and there is no need to open the abdomen to save the life. Now, different scenarios in this stable patient. Listen carefully, beta. Look at me on the screen. Look at me on the screen. Knife taken out. Patient is stable. Whether we should do something or not depends. If suppose the knife has not gone into the peritoneal cavity, that means if you look at the layers of the abdominal wall, there is skin, subcutaneous tissue, then in the center there is anterior rectus sheath, rectus muscle, and here there are other muscles. Then there is a posterior rectus sheath here, and then comes the peritoneum, and then you enter in the peritoneal cavity. Now, if somebody is hitting a knife and the knife has not gone into the peritoneal cavity, that means the knife is just in the abdominal wall. Maybe possible when the person was hitting with a knife, suddenly he remembers, no, this is bad, gandi baat, aise chaku nahi marte. So there is a possibility that suddenly when the person was hitting, he reduces the force, and because of that, the knife has not gone into the peritoneal cavity. Or maybe the patient is Salman Khan, 6 packs, somebody hits a knife, and suddenly the person makes that 6 packs, and now the knife gets coiled within the rectus muscle itself. Moral of the story, concept here is, knife has not gone into the peritoneal cavity. MCQ people want to know from you, would you like to go into the peritoneal cavity? अरे जब चाकू ही अंदर नहीं गया तो हम अंदर जाके क्या करेंगे? If the knife has not gone inside, then what we'll do by going inside? So there is no need of doing a laparotomy if there is no evidence of peritoneal breach. Clear? We'll just do a simple wound exploration and just do the dressing of this wound. Another scenario. The knife has gone into the peritoneal cavity, but the patient is stable. That means this knife has not caused significant injury to the vessels inside. जो blood vessels है ना अंदर, उनको ज़्यादा चोट नहीं पहुंची है. That is why the patient is stable. That means, ideally, there is no need to open the abdomen. But we also know that small intestines can also be injured by this penetrating object. But if suppose there is a small hole in the intestine because of this knife, then whatever is there inside the intestine, that will leak out into the peritoneal cavity. अगर मान लीजिए किसी ने पेट में चाकू मारा और चाकू किसी वेसल वूसल को नहीं लगा, तो पेशेंट कोई ब्लीडिंग नहीं हो रही, पेशेंट स्टेबल है. लेकिन ऐसा भी तो संभव है ना भैया कि ये जो चाकू है इसकी टिप जो है इंटेस्टाइन में कोई छेद कर दिया हो. अगर इंटेस्टाइन में कोई छेद हो गया है तो जो इंटेस्टाइन के अंदर का मसाला है वो इस छेद से बाहर आने लगेगा. And gradually what will happen if there is intestinal perforation, the intestinal contents leaking into the peritoneal cavity may cause peritonitis. But this symptom signs of peritonitis may take some time, maybe 24 hours, maybe 48 hours. That means in a penetrating abdominal trauma, if there is any evidence of peritoneal breach, the knife has gone into the peritoneal cavity, but the patient is stable. That means no major vascular injury, no laparotomy required to save the life. But we admit this patient in the hospital for 24 to 48 hours. If the patient develop any symptom or signs of peritonitis, then we have to do a laparotomy, do a peritoneal lavage, and deal with the intestinal perforation. Right? I hope this is clear, beta. Let me revise this once again for you, whatever we have talked in penetrating trauma till now. If there is a trauma by knife or something sharp object into the abdomen, if the sharp object is inside, we do a exploration in the operation theatre. If there is no sharp object inside and the patient is stable, then we see whether the knife has gone into the peritoneal cavity or not. If there is no evidence of peritoneal breach, no need of any laparotomy, just a simple wound exploration and dressing. If there is evidence of peritoneal breach, which the examiner can give you, like omentum is coming out, intestine is coming out, or when you are examining this wound, you can see that intestine peristaltic movements are seen. That means the knife would have breached the peritoneum. And even if the patient is stable, that means no major vascular injury which can cause bleeding. So no laparotomy is needed to save the life. But we still admit the patient for 24 to 48 hours because we know that this penetrating object might have caused some perforation in the intestine, because of which the intestinal contents would leak into the peritoneal cavity, can lead to peritonitis, and this may take even 24 to 48 hours for the patient to present with symptom signs of peritonitis. If patient develop these symptom signs, then yes, we have to do a laparotomy, do a peritoneal lavage and deal with the intestinal perforation. I repeat this in Hindi also बेटा. अगर मान लीजिए किसी ने पेट में चाकू मारा है, अगर पेट में चाकू छोड़ के भाग गया है और चाकू पेट में है, तो फिर हमें ऑपरेशन थिएटर में ही इस चाकू को निकालना हो, यानी कि जो भी एक्सप्लोरेशन है हमें करना हो. दूसरा सीन, पेट में चाकू मारा, चाकू निकाल के भाग गया, लेकिन पेशेंट स्टेबल है, पेशेंट की पल्स ठीक ठाक है, बीपी ठीक ठाक है. इसका मतलब भैया कोई चाकू से मेजर इंजरी तो नहीं हुई है, पेशेंट उसकी वजह से मरने वाला तो नहीं है. अब ये जो चाकू लगा है, हमें ये देखना है कि भैया ये चाकू पेरिटोनियल कैविटी के अंदर गया भी है कि नहीं. ऐसा तो नहीं कि जो पेट की दीवार है उसी में चाकू घूम के रह गया हो. अब चाकू ऐसे पेट की दीवार में कैसे घूम के रह जाएगा भैया. मान लो मारते वक्त जो मार रहा था उस समय उसको ध्यान आया, अरे भैया गंदी बात, ऐसा थोड़ी करते, तो उसने जो प्रेशर लगाया वो एकदम से रोक लिया, हाथ रोक लिया उसने, तो चाकू पेरिटोनियल कैविटी के अंदर गया ही नहीं. या मान लो पेशेंट की मसल्स बड़ी अच्छी थी, स्ट्रांग थी, सलमान खान टाइप, 6 पैक्स, तो जैसे ही चाकू मारा वैसे ही उसने ऐसे टाइट किया और जो चाकू था वो बेचारी रेक्टस मसल में कॉइल होके रह गया. यानी कि चाकू पेरिटोनियल कैविटी के अंदर गया ही नहीं. जब चाकू ही अंदर नहीं गया तो हम अंदर जाके क्या क्या करेंगे, है ना. तो हमें सिर्फ जो ये जख्म है इसको एग्जामिन कर लो, एक्सप्लोर कर लो और पट्टी कर दो. दूसरी कहानी, पेट में चाकू मारा गया है, चाकू निकाल के भाग गया है, पेशेंट स्टेबल है. इसका मतलब अगर पेशेंट स्टेबल है तो मरने वाला तो नहीं है. अगर मान लीजिए चाकू पेट के अंदर गया है, पेरिटोनियल कैविटी में गया है, पेरिटोनियम को ब्रीच किया है, यानी कि हो सकता है जो छेद दिख रहा है यहाँ उससे पेट के अंदर का सामान बाहर आता हुआ दिखाई दे, चाहे ओमेंटम आए, चाहे इंटेस्टाइन आए, या जब हम एग्जामिन करें तो हो सकता है जो इंटेस्टाइन की पेरिस्टालसिस है वो दिखाई दे जाए. अगर ऐसा कुछ भी है, इसका मतलब भाई साहब चाकू तो अंदर गया है, लेकिन पेशेंट ठीक ठाक है क्योंकि कोई मेजर वेसल की इंजरी नहीं है. लेकिन भाई साहब ये चाकू अगर पेट में गया है तो 6 मीटर लंबी वो स्मॉल इंटेस्टाइन है, क्या पता इस चाकू ने उसमें कोई छेद कर दिया हो. अब अगर चाकू ने इंटेस्टाइन में छेद किया है तो इंटेस्टाइन के अंदर जो मसाला है वो लीक तो मारेगा ही, लीक करेगा, पेरिटोनियल कैविटी में आएगा, उसको लीक करने में थोड़ा वक्त लगेगा, उसकी वजह से फिर पेरिटोनाइटिस होने में वक्त लगेगा, पेशेंट को सिम्टम साइन डेवलप करने में थोड़ा वक्त लगेगा. हो सकता है 2 घंटे लगे, हो सकता है 4 लगे, हो सकता है 24 घंटे लगे, हो सकता है 48 घंटे लगे. ये तो डिपेंड करता है भैया वो जो इंटेस्टाइन में चाकू गया है वो कितना बड़ा छेद किया इंटेस्टाइन में. छोटा सा छेद है तो बहुत टाइम लगेगा पेरिटोनाइटिस होने में, बड़ा छेद है तो हो सकता है घंटे भर 2 घंटे में आ जाए. यानी कि ऐसे पेशेंट को अपने को भर्ती कर लेना चाहिए और फिर 24-48 घंटे में देखना चाहिए कि भैया कोई पेरिटोनाइटिस के सिम्टम साइन आ रहे कि नहीं आ रहे. नहीं आ रहे तो बहुत अच्छी बात, लेकिन अगर कोई पेरिटोनाइटिस के सिम्टम्स आ रहे हैं तो फिर अपने को पेट खोलना पड़ेगा, अंदर जाके सारा झाड़ू पोछा लगाना पड़ेगा और फिर जो इंटेस्टाइन में छेद हुआ है उसको उसके हिसाब से बंद करना पड़ेगा. ठीक है जी. सो दिस इज द स्टोरी रिलेटेड टू पेनिट्रेटिंग एब्डोमिनल ट्रॉमा इन अ स्टेबल पेशेंट. If by chance penetrating abdominal trauma patient, there is major vessel injury inside, massive bleeding going on, patient will be unstable. Unstable, that means we have to be very aggressive in the management to save the life of the patient. We'll try our level best. We'll do that ABCDE, basic resuscitation, circulatory going to be most important. And in order to save the life of this patient, if massive bleeding is going on, we have to do a laparotomy, apply direct pressure to take control of the bleeding. So the same scenario is what we are going to do, what we have been following in unstable patients everywhere. Whether it is a chest trauma or an abdominal trauma. If the patient is hemodynamically unstable, then we do the basic resuscitation, and then we have to do surgical exploration, apply the direct pressure to control the bleed. If we compare the head trauma versus chest and abdominal, there is hardly any space inside the brain, inside the cranium, for massive bleeds. So brain bleeds will not present with hypovolemic shock. Brain bleed patients will not die of hypovolemic shock, but chest and abdominal bleeds will die of hypovolemic shock. So let us quickly take a look, beta, what all is written in penetrating abdominal trauma. I hope you are able to understand the concept of this penetrating abdominal trauma nicely. Any foreign body should be removed inside the operation theater under complete control. Depending on whether the patient is hemodynamically stable or unstable, if penetrating abdominal trauma, patient stable, we have to see whether the knife has gone inside the peritoneal cavity or not. That is any evidence of peritoneal breach, maybe by omental or intestinal prolapse. If there is no peritoneal breach, that means knife has not gone inside, there is no need to do a laparotomy. Just a simple wound exploration is what is needed. If the peritoneal breach is present, then we admit the patient for observation. We look for any signs, symptoms of peritonitis. You can write here, admit for 24 to 48 hours initially. See whether the patient is developing any peritonitis. If the patient is not developing any evidence of peritonitis, there is no need of doing a laparotomy. But if the patient is developing signs, symptoms of peritonitis, then yes, we have to open the abdomen, laparotomy. So I hope this is absolutely simple and clear in your minds. Now let us see what has to be done in a hemodynamically unstable patient. Unstable, we can understand there would be some major vascular injury. So we are trying our level best. We are trying to save the life of this patient. Basic resuscitation. And then we have to do a surgical exploration, that is laparotomy. Apply direct pressure and control the bleed. Right, beta G? Okay. The last thing in abdominal trauma, beta, this was a question asked on 31st of August 2020. We can divide the retroperitoneum into 3 zones. Before that, what I'll do, I'll just try to explain what is this retroperitoneal story here. God has given us a peritoneal cavity, a box inside. ओके हम सब लोगों के पेट में एक डब्बा है जिसको अपन पेरिटोनियल कैविटी बोलते हैं. When you are looking from anterior to posterior, right? Area which is in front of this peritoneal cavity, this is called as preperitoneal. Area on the side is called as extraperitoneal. And area behind this peritoneal cavity is called as retroperitoneal. Now what we are talking is retroperitoneal trauma. This retroperitoneum, beta G, can be divided into 3 zones. Zone 1 is the central zone where big people like aorta and inferior vena cava are lying. Aorta and IVC in zone 1. Zone 2, beta, this is the lateral zone. This is for the kidneys. And zone 3 is the pelvic retroperitoneum. Pelvic retroperitoneum. Okay. We know the concept of management of these all traumas. If there is injury to the retroperitoneum and the patient is unstable, that means there would be some massive bleed from here and there. We'll follow the same guidelines, beta. Pump in IV fluid, normal saline, pump in blood, platelet, fresh frozen plasma, tranexamic acid. But if the patient is unstable, the bleeding is not stopping, patient is dying, so in these cases we cannot wait and we have to do a surgical exploration. Apply direct pressure to control the bleed and save the life of the patient. Simple. If there is trauma to the retroperitoneum and the patient is stable, ideally, we should just admit this patient under observation, and generally the treatment should be non-operative. That is usually the case also, except if, ध्यान से सुनना बेटा, look at me on the screen. If there is trauma to zone 1, कौन से एरिया को trauma बेटा? Zone 1. If there is a trauma to zone 1, where aorta and IVC are there, and suppose the patient is stable also, then also we have to do a surgical exploration, because if there is even a small clot here, the chances of getting dislodged are very high, because these aorta IVC are having high pressures. So even if the patient is stable, but there is trauma to zone 1, we have to do surgical exploration. While trauma to zone 2 or trauma to zone 3, if the patient is stable, there is no need of surgical exploration. I hope the concept is clear, beta. If there is trauma to zone 1 retroperitoneum, and even if the patient is hemodynamically stable, then also we have to do surgical exploration, because here lies the important vessels, aorta and IVC. And we don't want to take any chances here. While trauma to any other zone, whether it is zone 2, zone 3, if the patient is unstable, whether it is zone 1, zone 2, zone 3, patient unstable, it will require surgical exploration. Trauma to zone 2, zone 3 retroperitoneum, patient stable, usually does not require surgical exploration. Trauma to zone 1 retroperitoneum, patient stable, will always require surgical exploration. Right, beta? So in all the traumas what we have discussed, whether it is a head trauma, face trauma, neck trauma, chest, abdomen, one concept which is absolutely clear in our minds, if the patient is unstable, probably there is a major vascular injury, patient is going to die because of huge amount of blood loss. We are trying our level best for basic resuscitation, but majority of the times we have to do a surgical exploration, apply direct pressure to control the bleed and save the life of this patient. There are two exceptions where even if the patient is stable, we might have to do surgical exploration. One is a zone 1 retroperitoneal trauma where aorta and IVC are there. Even if the patient is stable, we are doing a surgical exploration. And second, a penetrating abdominal trauma where the patient is stable, we admit this patient for observation. If the patient develops symptom signs of peritonitis, then we do exploration for intestinal perforation, not to save the life there, right? Chale beta. So I hope this entire story of trauma is absolutely clear in your mind. Here, if you take a look at this picture, beta, now this what you are seeing in the retroperitoneum, this whole area, this is what is zone 1. And in this zone 1, you can see the important people. This is the inferior vena cava, and this is the abdominal aorta. Right? So even if the patient is stable, we are doing surgical exploration for zone 1. On the sides, beta, this what you are seeing on the sides, this is the zone 2, which is the zone for kidneys, and this is the pelvic retroperitoneum. If the patient is unstable, they will always require exploration, but if the patient is stable, they usually do not require exploration except for zone 1. So here, if we take a look, zone 1 is the central zone where there is aorta and inferior vena cava. Zone 2 is the lateral zone for kidneys. And zone 3 is the pelvic retroperitoneum, where there are pelvic organs. Zone 1 always require surgical exploration. Always require surgical exploration. Even if patient is stable. Even if patient is stable. While zone 2 and zone 3 will require exploration if patient is unstable. Trauma to zone 2, zone 3 will require exploration only if the patient is unstable. Zone 1, zone 2, zone 3 will require surgical exploration if the patient is unstable. Zone 1, even if the patient is stable, will also require surgical exploration. On 31st of August 2020, they gave this image and they asked, this was the image given on 31st of August 2020, and they asked that out of these zones, which zone will always require surgical exploration even if the patient is stable? And the options what they gave beta G, the options were something like this: zone 1 and 2, zone 1 and 3, zone 2 and 3. Now, we know right now that the answer should be zone 1, that which will require surgical exploration even if the patient is stable. But when it was 17th of December, beta, 17 December, or we can say 31st August 2020, so the date itself, the exam date itself, creates a lot of anxiety inside us. And when we keep on practicing solving different MCQs, we gradually come to know that usually the longer options are more likely to be the correct answer. So though we know that the answer for this is zone 1, but just because of the exam anxiety, we tend to get confused. Ki bhai, what was written in the notes? Whether it was zone 1 or it was something else. There was zone 1 and then there was zone 2 and 3. So zone 1 is a very small option. This cannot be the answer. And that creates the confusion. And then you start thinking about others and you may land up in marking any of these options, right? So we have to be very, very careful. We have to be very clear in our thoughts. We have to be very clear in our concepts so that we do not forget the answers easily. Why we are doing exploration for zone 1, beta? Because there is aorta and inferior vena cava in the zone 1. Right? These are major vessels. Even slightest of injury, even a small amount of clot in zone 1, if it dislodges, it will lead to profuse bleeding and the patient will die. So we don't want to take any chances for zone 1 retroperitoneal trauma. Right. So I hope, beta, that the entire story is absolutely clear in our minds. We have talked about the head trauma, where we talked about scalp, skull, brain. We talked about face today, the mandibular fractures mainly. We talked about neck, the different zones in the neck. We talked about the chest trauma, the different pneumothorax, hemothorax, hemopneumothorax, tension pneumothorax, cardiac tamponade, sucking wound or open pneumothorax, flail chest. Then in the abdominal trauma, we talked about blunt abdominal trauma stories, patient stable, unstable. We talked about penetrating abdominal trauma stories, stable, unstable. We talked about retroperitoneal trauma stories, stable, unstable, right? And I hope you have got a nice concept inside you. And I'm pretty sure, beta, that if you learn these concepts nicely, even in your clinical practice, these are the things which you will keep on reminding yourself, and you will be able to save many lives in your life. And then we'll feel that yes, whatever we are discussing, that has added some value in your life. Now, moving from this specific organ traumas or specific area traumas, there are few small things which are related to trauma, like something related to shock, something related to bleeding, something related to blood transfusion. So let us see what those simple little things are. शॉक का नाम सुनते ही ना शॉक लग जाता है. Shock is so simple, beta, to understand. It is simply whenever the oxygen supply to different tissues is not adequate. शॉक का मतलब क्या है? जब जो हमारी बॉडी में टिश्यूज है ना बेटा, अगर उनको ऑक्सीजन ठीक से नहीं मिल रही तो हम उसको शॉक बोल देते हैं. Now, what can be the different reasons for this shock? We know that it is the arteries which are supplying oxygen to the different tissues in the body, right? And we know God has given us a pump, that is heart, which is supposed to pump the blood to different parts of the body. We know there is something which comes out from the left ventricle, and that is the aorta. That is carrying the oxygenated blood. So if we just try to focus on this diagrammatic schematic view, this, what we are seeing here, this is the heart, right? Suppose this is the right atrium, here this is the left atrium, this suppose is the right ventricle, and this suppose is the left ventricle. And we know that there is something which is coming out from the left ventricle, that is the aorta. And then aorta is dividing and giving off branches here and there to different organs. That is how the oxygenated blood is going into the different organs. The organs are utilizing this oxygen, and then deoxygenation is taking place. Now this deoxygenated blood is transported back through the capacitance vessels in the body, which are the veins. And these capacitance vessels are coming into the right atrium, right? And from there, this deoxygenated blood is going into the right ventricle. From here, it is going via pulmonary artery into the lungs. From pulmonary artery, the blood is getting oxygenated, and then this oxygenated blood is coming into the left atrium, and then into the left ventricle, and this cycle keeps on going. है ना बेटा? अब there are 4 terms which are commonly used: cardiogenic shock, hypovolemic shock, septic shock, neurogenic shock. When we hear the names, we are not able to understand ki bhaiya, what is the actual story in this. Let me just give a little finishing touch in this schematic diagram. This is the right atrium, this is the left atrium, this is the right ventricle, and this is the left ventricle. Right. Now it looks a little better, right? Abhi beta, what is cardiogenic? When heart is not able to pump oxygen out, that is cardiogenic. Now, why the heart is not able to pump oxygen out, beta? Why the heart is not able to pump oxygen? Suppose kariye, there is a penetrating trauma, and this has caused injury to the heart muscle. अगर किसी ने छाती में चाकू मारा और हार्ट की मसल इंजर हो गई, so now what will happen? The heart will not be able to contract properly. So oxygen will not be pumped outside. Oxygen will not be reaching into the tissues. This is a type of cardiogenic shock. If suppose there is myocardial infarction, suppose we know there are coronary vessels which are supplying oxygen to the heart. If suppose there is a traffic jam in some of the coronary artery, and now because of this traffic jam in the coronary artery, the oxygen is not getting supplied to the heart muscle in some area, because of which that part of the heart muscle is suffering from ischemia, and it may become infarct. and now this part is not allowing the heart to contract properly. So again, the oxygen is not going into the tissues properly. This is also a type of cardiogenic shock. Or sometimes if I say that there is injury, and because of the injury there is a massive amount of blood or fluid has collected around the heart. Suppose there is massive amount of blood or fluid has collected around the heart, like we saw in cases of cardiac tamponade. Now what is happening? This fluid is not allowing the heart to contract. So how will the oxygen be pumped to the circulation? This is also a type of cardiogenic shock. जब हार्ट भाई साहब जो हैं ये ऑक्सीजन नहीं भेज पा रहे हैं आगे, चाहे इनको चोट लगी हो, चाहे इनका इन्फार्क्ट हुआ हो, चाहे इनके बाजू में खूब सारा ब्लड इकट्ठा हो गया जिसकी वजह से हार्ट भाई साहब कॉन्ट्रैक्ट नहीं कर पा रहे हैं, अगर इस कारण से ऑक्सीजन नहीं पहुंच रही है टिश्यूज में तो इसको बोलते हैं कार्डियोजेनिक शॉक. राइट नाउ इफ वी कम टू दिस, the pipeline, the blood pipeline, any trauma to the body, whether it is a femur fracture, liver, spleen, thoracic, or any trauma beta, whenever there is a bleeding going on, we all can understand that if this is the boundary of the blood vessel, suppose, and there is a injury here, so what is going to happen? If there is injury here, the bleeding, the blood is leaking out. So this blood is leaking out. That means the oxygen is also leaking out na beta. Oxygen bhi to bahar nikal rahi hai. So if oxygen is also leaking out, that means proper oxygen is not getting supplied to the tissues. That means this is what is a hypovolemic shock. This is the most common shock seen in trauma patients. This is also called as hemorrhagic shock. Another story beta. Now this what we are seeing, these are the organs, suppose. Like suppose this is the kidney, right? Now in this kidney, if suppose there is a bacterial party, suppose there is severe bacterial infection here. Because of the infection, there would be severe inflammation, and in inflammation beta we know there is vasodilatation. So the vessels of the kidney here, they will get dilated, and because of this they will be drawing more amount of blood towards the kidney. So when more amount of blood is coming towards the kidney, that means the other organs will be facing deficit of blood. That means the other organs are deprived of oxygen, and this type of shock, which is due to infections, sepsis, is what we call as septicemic shock or a warm shock. This is not because of bleeding. This is just because of vasodilatation. More amount of blood has gone to some area inside the body so that the other organs are facing deprivation of oxygen. This is what is a septic shock or warm shock. Now another story beta. We know that whatever oxygen is used, that comes back. The deoxygenated blood is coming back towards the right atrium, right? Sometimes what can happen beta, look at the screen carefully beta, ध्यान से देखिएगा. कभी कभी क्या हो सकता है बेटा, if suppose these capacitance vessels they dilate, if these vessels dilate, now what is going to happen? All this deoxygenated blood that is going to get pulled into this circulation in the veins. If the veins are getting dilated, veins are the capacitance vessels of your body beta. You have got 5 liters of blood. 70% of this 5 liter is staying inside your veins, and by chance if the veins dilate, then this blood will remain pulled inside the veins. That means the blood will not be coming properly into the heart. यहाँ नहीं आ रहा है. This is not happening. All the blood is getting stored here itself, Now, if the blood is not coming into the right atrium, it is not going into the right ventricle, it is not coming into the left atrium, it is not going into the left ventricle, it is not going into the aorta. That means there will be deficiency of oxygen here, right? So the tissues are not going to get oxygen properly. This is called as neurogenic shock. Why these veins get dilated, beta? Whenever the sympathetic tone is lost, this causes dilatation of the veins. For example, if you look at the brainstem, cervical spine, thoracic spine area, where there is autonomic nervous system, the sympathetic nervous system, if there is any trauma to the brainstem, cervical spine or thoracic spine, this causes sympathetic block, and because of this, the veins get dilated. Blood remains pooled inside the veins. Blood does not come back to the heart. So how this heart will be able to pump the blood into the aorta? Sometimes when we are giving spinal anesthesia, that is a regional anesthesia, if by chance this anesthetic drug in the lumbar space, it moves up towards the thoracic spine and the cervical spine area, it can cause blockade of the sympathetic system. And then also these veins get dilated and patient may go into neurogenic shock, right? So what we have talked about, beta, क्या बातें की हमने? 4 चीजें: कार्डियोजेनिक, hypovolemic, septic, neurogenic. Cardiogenic, whenever the heart is not able to pump the oxygen out. Hypovolemic or hemorrhagic, all trauma patients if there is bleeding. Septic, when there is infection in some particular area of the body. Neurogenic, when the sympathetic tone of the veins is lost and the veins have become dilated, right? Chale, I hope it I am able to do some justice here and give you a small brief idea about these different types of shock. Okay. So here in beta, if we take a look, what is the definition of shock? It is inadequate organ perfusion and tissue oxygenation. Most common in trauma patients is a hypovolemic shock. Most common in trauma patients, it is hypovolemic shock. अभी इनके बारे में देख लेते बेटा one by one. Now this what you are seeing, this is a cardiogenic. When the heart muscle contractility goes down, maybe either due to direct trauma to the heart, maybe due to cardiac tamponade, or maybe due to myocardial infarction. Whatever is the reason. Maybe due to myocardial infarction. Then there is a neurogenic shock, beta. Neurogenic, we just discussed. If there is any trauma to the brainstem, cervical or thoracic spine, there is loss of sympathetic tone. This causes veins to dilate, that is capacitance veins, because of which the blood gets pooled in the veins. And that is why the blood is not coming back towards the heart. Then there is a septic shock. Septic shock is called as warm shock because there is no blood loss here. It is due to infections. If we talk a little detail about the hypovolemic shock, beta, the first or the earliest sign in hypovolemia is tachycardia. You know that already. Cutaneous vasoconstriction is also an early sign of hypovolemic shock. Fall in systolic blood pressure is a late sign. If more than 30% blood loss has occurred, then the systolic BP starts falling. Now, various definitions of tachycardia. However, one accepted definition in ATLS, if we are talking about an adult, heart rate more than 100 beats per minute. If we are talking about a school-going child, more than 120. Preschool child. Now, preschool, school जाने से पहले 3 to 6 years of age. and infant is less than 1 year of age, more than 160 beats per minute, right? In this hypovolemic shock, beta, if the patient is bleeding, we have to save the life now. To save the life, we follow the same guidelines, beta. A, B, C, D, E. We pump in IV fluids, beta. What is the initial fluid of choice? Crystalloid. Which fluid we are using normally, beta? It is normal saline. Though we can use Ringer lactate as well. We give blood, platelets, fresh frozen plasma. We give a hemostatic injection, tranexamic acid. If nothing is helping, beta, and the patient is bleeding, then we have to control the bleeding by applying direct pressure. For this, we have to do surgical exploration, and that is how we are able to save the life. Right? So the same story has been repeated. The only thing, beta, the information what we got here was something here. So what is tachycardia, beta? Adult may more than 100 beats per minute, school going more than 120, preschool more than 140, and infant more than 160. एक बार इसको याद करेंगे बेटा. Let us learn this, beta. In an adult, more than 100, school more than 120, preschool more than 140, infant more than 160. Once again, let's do it, beta. Adult में कितना बोलते हैं tachycardia? Very good. School going, preschool, infant. Once again, let's do it. Adults, school, preschool, infant. Let's do it once again, beta. Adults, school going, preschool, infant, preschool, school, adult, preschool, school, infant, adult, school, preschool, infant, adult. स्पीक आउट बेटा, स्पीक आउट बोलना है, वोकल कॉर्ड से बोलना है. एडल्ट में कितना है टैकीकार्डिया? स्कूल गोइंग, प्री स्कूल, इन्फेंट. वंडरफुल. पर जोरदार पानी बजा दो अपने लिए. Right. So basically, this is the information what we got in this section. Now let's take a look, beta, at some small points related to hemorrhage. Now this hemorrhage simply means bleeding, right? As a doctor, how we can measure that how much amount of blood has been lost? Let us try to just understand कि we are the doctors, beta, we are the surgeons, suppose, and you are operating. During operation, you are carrying a knife, you are carrying the instruments, you don't carry any beaker or any measuring device to measure कि भैया you have cut this area, now there is bleeding, and so you collect that blood and you measure that how much amount of blood is lost in this patient, right? So this is something which is not practically possible. But we have got some crude values by which we can have an idea that how much blood would have been lost in this patient. For example, suppose you are doing a laparotomy, किसी के पेट का operation कर रहे हो बेटा, and there is bleeding, and now the blood clots are getting collected here and there, maybe in the pelvis. Now when you dig into the pelvis and you take out the clots, now these clots in a fist, this is equal to 500 ml of blood. When we talk in orthopedics, in the different fractures, like humerus and tibia fractures, we consider the blood loss should be around 750 ml. In femur fracture, 1500 ml. Pelvic bone fracture, 2000 ml. Another way of assessing the amount of blood loss, there is a colorimetric method. That is a hemoglobin estimation. What we do is, if you are doing any operation, beta, then you get the hemoglobin done before the operation. You can also get the hemoglobin done after the operation. You just subtract the post-op hemoglobin from the pre-op hemoglobin. Suppose there was a patient who was having a hemoglobin of 12 gram %, and you have done some surgery in this patient, and after surgery the hemoglobin has dropped to 10 gram %. I repeat this in Hindi बेटा. एक क्रूड सा तरीका है देखने के लिए कि भैया कितना खून गया ऑपरेशन में. तो ऑपरेशन से पहले हीमोग्लोबिन देख लो, ऑपरेशन के बाद देख लो. जो ऑपरेशन के बाद वाली वैल्यू है उसको ऑपरेशन से पहले वाली वैल्यू से माइनस कर दो. सपोज ऑपरेशन से पहले 12 ग्राम % तो ऑपरेशन के बाद 10 ग्राम % रह गया, यानी कि कितने का नुकसान हुआ. दैट मीन्स हाउ मच अमाउंट ऑफ ब्लड हैज बीन लॉस्ट. कितने % ऑफ हीमोग्लोबिन? 2 ग्राम %. Now 1 gram % beta, 1 gram % of hemoglobin is roughly taken as 1 unit of blood. That is approximately 450 ml of blood. In the given example, what we are talking about, 2 gram % means how much amount of blood loss? So 1 gram % is 450. 2 gram % is 900 ml. So that is how we can get some idea how much amount of blood loss has occurred. We can also categorize the blood losses into different categories, class 1, 2, 3, 4. Now, this is something which is important, and this is a high chance of being asked in your exams. Class 1, class 2, class 3, class 4 blood loss. You would have seen the tennis game, beta, lawn tennis. Many of you would have played the lawn tennis also. You know? So when you are watching the tennis game, the scores in the tennis game, 0 to 15, 15 to 30, 30 to 40, more than 40. Can you repeat this with me, beta? 0 to 15, 15 to 30, 30 to 40, more than 40. एक बार फिर से करेंगे बेटा. 0 to 15, 15 to 30, 30 to 40, more than 40. Can you do it once again? 0 to 15, 15 to 30, 30 to 40, more than 40. Once again. 0 to 15, 15 to 30, 30 to 40, more than 40. Okay. What is this beta? 0 to 15, 15 to 30, 30 to 40, more than 40. Once again, right? You have to speak out, beta. Speak out, and speak out loudly. I hope you are not in the library, right? Okay. If you are in the library, just do it inside, right? So class 1. Now let's do it fast, huh? Zero to 15, 15 to 30, 30 to 40, more than 40. Right? What is this? What is this? What is this? What is this? Perfect, beta. Wonderful. Very good. Keep it up. Keep yourself pumped up, right? Keep yourself pumped up. Keep yourself focused all the time. This is going to be very crucial for 17th of December. We might get a question here, right? Okay. Chaliye. So let's come back and let's see what all is written here. To measure the amount of blood loss, beta, blood clot in a clenched fist. This is equal to 500 ml. If we are talking about closed fractures like humerus and tibia, 750 ml blood loss. Femur fracture, 1500 ml blood loss. Pelvic fracture, 2000 ml blood loss. Another is a colorimetric method for hemoglobin estimation. Very simple. Pre-op hemoglobin minus post-op hemoglobin. This gives us the value in X gram %. And 1 gram % of hemoglobin is equal to 1 unit of blood, which is generally taken as 450 ml of blood. There are various categories of blood loss. Class 1, 0 to 15%. Class 2, 15 to 30%. class 3 30 to 40%, and class 4 more than 40%. They can even ask in values, beta. So suppose somebody is having 5000 ml of blood inside the body. Now herein, if we have to calculate 15%, if we have to calculate 30%, if we have to calculate 40%, so what we'll do something like this. Right, beta? So this comes out to be 750. This comes out to be 1500. This comes out to be 2000. That means 0 ml to 750 ml is class 1. Then 750 ml to 1500 ml is class 2. Then 1500 ml to 2000 ml is class 3. And more than 2000 ml is class 4. Right, beta? So these can be the values which can be asked in your exams. Generally, class 1 blood loss is something which is just relatable to a 1 unit of blood donation. I'm pretty sure, beta, many of you would have donated blood. So when you donate blood, it is not that you require any IV fluid infusion or something like that. Your body is capable enough to adapt to these small amount of blood loss. So 0 to 15% of class 1 blood loss categories, they are rapid responders. They do not require any intervention as such. Class 2 and class 3, when more amount of blood loss has occurred, we have to pump in IV fluids and we have to see whether we are able to revive these patients or not. Many times we are able to revive, but sometimes these patients may not be revived. And class 4, they do not respond to any IV fluids or something. We have to do surgical exploration and take control of the bleed. Herein, I would like you, beta, that you can make a small table. Just make a small table here. In this, we are going to discuss some parameters. Like suppose here we talk about categories: class 1, class 2, class 3 and class 4. And here, if we talk about pulse, respiratory rate, then systolic blood pressure, urine output and Glasgow Coma scale. Okay, beta? So we are just trying to see what is the status of these 5 parameters in these different categories of blood loss. अभी बेटा हमने बात किया, we just talked कि class 1 category is just like you have donated 1 unit of blood. That means in class 1 blood losses, the story remains normal. है ना बेटा? So in class 1 beta, if you look at the pulse rate and respiratory rate, the pulse is less than 100 beats per minute. Adults में tachycardia is more than 100, right? And respiratory rate is less than 20 beats per minute. Systolic blood pressure, urine output, and Glasgow Coma scale, everything is normal beta, right? In class 2 blood loss, what happens? The pulse rate can be between 100 to 120 beats per minute. Respiratory rate can be 20 to 30 per minute. अच्छा बेटा एक चीज बताओ मेरे को, जस्ट टेल मी वन थिंग कि systolic blood pressure starts falling when there is more than MCQ% of blood loss. What was that value? Very good, more than 30%. Okay, now tell me beta, what is class 1? 0 to 15. Class 2, 15 to 30. And systolic BP starts falling when there is more than 30% blood loss, right? That means systolic blood pressure will remain normal in class 2. Urine output will also be normal. GCS will also be normal in class 2. It is in class 3 beta that this systolic BP will start falling. And when systolic BP will start falling, then the urine output will also start falling and blood supply to the brain is also getting hampered. So patient will present with some loss of consciousness and changes in eye verbal motor responses, right? In class 4 beta, there will be marked decrease. This is something which is simple. In urine output in class 4, it is almost negligible, or you can say it is almost nil. Almost nil. Urine output is almost nil in class 4 blood loss. Achha, coming to pulse and respiratory rate beta. In class 3 blood loss, pulse rate is between 120 to 140 and respiratory rate is between 30 to 40. And in class 4 beta, more than 140 pulse rate and more than 40 respiratory rate होना चाहिए था, but according to ATLS guidelines, this is more than 35. Right? So, how this table can help you in your exam beta? The examiner may create a clinical scenario कि there is a trauma patient who presented to you with pulse rate of say 130 beats per minute, respiratory rate of 32 per minute, systolic blood pressure 90 millimeter of mercury, urine output less, GCS suppose 12. Now, how much amount of blood loss do you expect in this patient? And the options can be 500 ml, 1000 ml, 1600 ml, 2200 ml. I repeat the question beta, you might get a question, road traffic accident story, pulse rate 130 beats per minute, respiratory rate 32 beats per minute, systolic blood pressure 90 millimeter of mercury, urine output decreased, and Glasgow Coma Scale suppose 12, right? That means this roughly 130 beats per minute pulse, this belongs to class 3, respiratory rate 32 again class 3, and systolic BP urine output GC is going down. So class 3. Now class 3 is what? 0 to 15, 15 to 30, 30 to 40 and more than 40. So 30 to 40% blood loss. Now 30 to 40% is how much? Less than 750 is class 1, 750 to 1500 is class 2, 1500 to 2000 is class 3 and more than 2000 is class 4. So out of the given option, what is the value between 1500 to 2000? So he gave the options like 500, 1000, 1600 and 2200. So 1600 is going to be the correct answer, right? So this is how this table may help you in maybe question here and there, right? So this is all about the story of bleeding. Now beta, what we'll do is we'll take a short break here, 10 minutes break. Let's take a break of 10 minutes. And then we'll be back at 7:37 p.m. and we'll discuss something related to blood transfusion, right? Thank you very much for your patient listening, beta. And please, please, please be ready with your queries. Once we are done with this blood transfusion, then I'll be taking up your queries. Right, beta. Right. So now let us discuss something related to blood transfusion. I hope you would have had something. Chale. I'm pretty sure that many of you would have donated blood in your life. So let us talk some small things related to blood transfusion and how they can be relevant for us on 17th of December and how they can be relevant for us in our clinical practice. So let us just try to understand a few things about this blood transfusion. Right. So herein, if we just try to focus when you are donating the blood beta, then they are putting a wide bore needle. They're putting a wide bore needle into the median cubital vein, and generally this median cubital vein is what is being used. So whenever we are drawing any blood sample, we do understand that we are tying some tourniquet or we are tying some pressure bandage. That is basically to just give me a moment. Yeah, that's fine. So we are just tying a tourniquet here so that we can stop the blood going back towards the heart. Right? Whenever you draw any blood sample, beta, you know that you are putting pressure here so that the vein gets occluded and the blood does not go towards the heart. So all the blood gets pooled here in this vein and you can easily draw the blood. Now, what should be the pressure here in the tourniquet? It should be sufficient enough to occlude the vein, but it should not be more so as to occlude the artery. If you look at the blood pressure, what you're having right now, beta, 120 by 80 millimeter of mercury. So 120 is the pressure which would be there in your arteries and 80 would be the pressure in your veins, right? So the pressure in the BP cuff for the tourniquet, what we tie whenever we are taking the blood for donation, this should be equivalent to the diastolic pressure of the donor, which is sufficient to occlude the vein, but not to occlude the artery, so that the blood starts flowing in the artery. And when the blood is coming back, it is not allowed to go towards the heart. Rather, we put a needle and we take out the blood. When you are donating the blood, you are given a sponge ball in your hand, which you keep on squeezing. That is to increase the demand so that the supply of blood is more and more blood can easily be collected. Generally, we take out 300 or 350 ml of blood, and this blood is going into a pre-sterile plastic bag. This bag is kept on a machine which keeps on doing this swaying movement, because in that plastic bag there are anticoagulants. The Sagam is something what we are using nowadays. So this blood which is going into the blood bag is continuously getting mixed with that anticoagulant so that clots do not form in that bag. Once this 350 ml of blood is taken, then we disconnect, send this blood bag to the blood bank. Their proper testing of this blood is done, especially for some infections which can be transmitted through blood, like HIV, hepatitis B, hepatitis C, malaria. So we do these testings, and then this blood is stored at a temperature of 4 plus minus 2 degrees centigrade in the blood bank refrigerator. We can prepare different fractions from this blood, like we can prepare the RBC concentrates, we can prepare the platelet concentrate, we can prepare the fresh frozen plasma, which is a rich source of clotting factors. Blood is usually kept at around 4 plus minus 2 degrees centigrade. Fresh frozen plasma is kept at minus 40 degrees centigrade. Sagam is the anticoagulant what we are using. Now, when we have to transfuse this blood, again, what we have to do is, for blood transfusion, we have to warm this blood before it is given to the recipient, because the temperature of this blood bag is 4 degrees centigrade, and before you transfuse it to the recipient, you have to bring it to the body temperature, that is 37 degrees centigrade. So what we can do is we can wrap this blood bag in a warm blanket for half an hour. In Indian scenario, in Indian hospitals, we ask the attendant who has brought the blood to keep this bag inside the clothes and close to the body, so that the blood comes similar to the body temperature. We should not keep this blood for more than 2 hours at higher temperatures, because blood is a very good culture media for the growth of microorganisms. So if you keep this blood at high temperatures for a longer period of time, there may be bacterial party inside this blood. And if you transfuse this blood, this can lead to serious infections in the recipient. Whenever we are transfusing this blood, first we have to do a proper grouping and cross matching. Then we use a special type of tubing, which is called as a BT set, blood transfusion set. क्या बोलते बेटा इसको? BT set, blood transfusion set. This BT set, apart from the air chamber, there is a filter also of 40 micron size. Why there is a filter in this tubing? Because if by chance there are any blood clots in the bag, we do not want these large molecules to go into the recipient. So there is a filter so that any molecule which is more than 40 microns does not go into the recipient. If you allow large clots going into the recipient, these clots can create a traffic jam in the kidneys of the recipient, and then the kidneys can fail. Right. When we are transfusing this blood, sometimes we can see some complications, like maybe there is a fever in the recipient. This is most often due to pyrogens in the donor apparatus. Donor apparatus means the bag, the tubing, the cannula. You would remember that in olden days, we used to use glass. Glass bottles were there, glass syringes were there. ध्यान है बेटा, पुरानी हिंदी फिल्मों में आपने देखा होगा, वो अमिताभ बच्चन साहब की फिल्मों में, कि कैसे वो कांच की खून की बोतल हुआ करती थी, कैसे वो कांच की सिरिंजेस का इस्तेमाल किया करते थे हम लोग. Now we don't see any glass here and there. We just see that plastic. The reason is silica in the glass was creating more pyrogens. So whenever that glass was used, the infection, the fever in the recipient was high. That is why now all the glass has been replaced by plastic. Sometimes we see ABO incompatibility in the recipient. That is mismatched transfusion, wrong blood group. Why? It is most often due to clerical error. For example, if you are collecting blood sample of say 5 patients, 5 patients have to be given blood today. So before that you take the blood sample for their grouping. Now many times if you don't prepare the label before you draw the sample, there is a risk that you collect those 5 vials, and now when you bring those 5 vials and you are putting the label, you might change the sequence, or by mistake the sequence might have been changed, and then you prepare wrong registration details on the vial. So this is how a wrong blood can be transfused in the recipient. And Betaji, why this is so important for us to understand? Look at me on the screen. Just imagine that suppose you have to give blood to a A positive blood group patient. That means the patient would be having A antigen on the RBC and antibody against B antigen in the plasma, that is anti-B antibody in the plasma. By chance, you give B positive blood to this A positive patient. B positive blood means B antigen on the RBC, antibody against A antigen in the plasma. If you give B antigen In a patient who is having anti-B antibody, there will be antigen antibody reaction, and this is going to form large clumps in the circulation. And just imagine, beta, if these large clumps are traveling in the circulation, they would be going into the kidneys of the recipient, and they can create a complete traffic jam situation in the kidneys of the recipient. No filtration will occur. Oliguria, urine output will decrease. Sometimes those clumps which are stuck in the nephrons, they may be squeezed through the nephrons, and you may find hemoglobin in urine, hemoglobinuria. Because of traffic jam in the kidneys by these clumps of antigen antibody reaction, the kidneys can fail. A small clerical mistake of by mistake the sequence of the vials have been changed, you might cause kidney failure of the recipient, which may require infusion of diuretics, which may require dialysis, and rarely it may even require kidney transplants. Just a small clerical error and kidney transplant in the recipient is not acceptable. That is why it has become a law in India that now you cannot draw any blood sample in an unlabeled vial. The vial has to have a label with the details written before you put the blood sample into that vial. I am pretty sure, beta, that all of you would have been giving your blood samples in recent times, and you would have taken notice about this, that whenever your blood is taken, the vial where your sample has to be put, the vial has a label already, and the details of you are already written on that vial. Then only the blood can be put in that vial. That is how we can minimize the risk of this mismatched blood transfusion. Apart from this, beta, in blood transfusions, sometimes air can lead to air embolism. Sometimes thrombophlebitis can occur. Thrombophlebitis, phlebo means vein. So suppose you are putting a cannula here, you may find that there is a sign, there are signs of acute inflammation in this area, maybe Ruber tumor, Calor, Dollar in this area. Probably the superficial vein has got inflamed. And that is because if you are not cleaning this area properly before doing a needle prick, I repeat this in Hindi, beta, अगर हमने इस इलाके को अच्छे से साफ नहीं किया, हमने डायरेक्टली अगर नीडल डाल दी, now if you are putting a needle directly without cleaning this area, the staphylococcus in this area, that may enter with the needle into the vein, that is into the blood. And bacteria ko blood pasand hai. Bacteria loves blood. So there will be staph party inside the blood, and this can lead to acute inflammation. This is what is thrombophlebitis. Various infections can also be transmitted through blood, like we were talking about HIV, hepatitis B, hepatitis C, and malaria. Recently, beta, 4th of June 2022 and NEET PG 21st May 2022, there was a similar question almost. Which of the following infection is not transmitted through blood? Or which of the following is not transmitted via blood transfusion? In NEET PG 21st May 2022, options were HIV, hepatitis B, malaria, dengue. So we know that HIV, hepatitis B, hepatitis C, and malaria can be transmitted. Dengue cannot. This was NEET PG. FMG 4th June. Which of the following is not transmitted via blood transfusion? Options were hepatitis A, hepatitis B, hepatitis C, HIV. So the answer was, क्या आंसर था बेटा? Hepatitis A, right? So this is how they can frame the questions related to this. Let's see what is written in the workbook. Right, beta. So storage temperature of blood, this is 4 plus minus 2 degrees centigrade. That means 2 to 6 degrees centigrade. Nowadays, what we are using is a Sagam blood, beta. Sagam, S stands for sodium chloride, A for adenine, G for glucose, M for mannitol. And this blood can be stored for 5 weeks. Shelf life is 5 weeks. Earlier, beta, we were using other anticoagulants like CPD and CPDA. CPD, citrate, phosphate, and dextrose. But the shelf life of this CPD was 21 days and shelf life of CPDA was 28 days to 35 days. And now we are using Sagam, which has got at least 35 days, sometimes even 42 days. Before we transfuse the blood, we have to do the warming. This is to avoid hypothermia. We do this warming for half an hour. This should not be done for more than 2 hours. Otherwise, there is risk of bacterial infection. If you keep the blood at higher temperature for a longer period, this can lead to infections. We ideally wrap the blood bag in a blanket for warming. We check the blood group. We use a special type of BT set which has got a filter, and the size of the filter is 40 microns. Various complications of blood transfusion. There can be transfusion reactions. Simple pyrexial reaction. This is due to D/T beta. This is due to pyrogens in the donor apparatus. Another complication what we can see is a ABO incompatibility, that is mismatched blood transfusion. Most common cause of wrong blood transfusion is a clerical error. This causes antigen-antibody reaction, large clumps, renal failure can occur, which will require diuretics or maybe even dialysis. Most common symptom what we see in the recipient after mismatched transfusion is pain and heat sensation. Pain and heat sensation along the vein. Most common sign what we see in mismatched transfusion is oliguria. This is more common than hemoglobinuria. Sometimes, suppose you are the surgeon and you are doing the operation, and during operation, suppose there is significant bleeding, the anesthetist has transfused some blood. As a surgeon, how you can come to know that a wrong blood has been transfused? If wrong blood is given, then you might see generalized oozing of blood from the cut surfaces in front of you. So generalized oozing of blood from the cut surfaces is one of the important signs of mismatched blood transfusion, especially if you are the surgeon and the anesthetist has given the blood. So anesthetized patient, unconscious patient, we may find generalized oozing of blood from the cut surfaces. Another complication what we can come across is air embolism, thrombophlebitis. This is inflammation of the superficial vein. Inflammation of the superficial vein. Various infections can be transmitted through blood. And beta G, this was a question in NEET PG as well as in FMG exam. Hepatitis B, hepatitis C, HIV and malaria. These are the infections which are transmitted through blood. In NEET PG, the options were HIV, hepatitis B, malaria, dengue. Answer was dengue. In FMG exam, options were HIV, hepatitis A, hepatitis B, hepatitis C. Answer was hepatitis A. Apart from this, beta, there is a thing called as massive blood transfusion. Now, massive we can understand when huge amount of blood is being transfused. if more than 10 units of packed RBCs are transfused within 24 hours, or we can say more than 4 units of packed RBCs transfused within few hours, or some books even write it as 1 hour. If more than 10 units of packed RBCs are transfused within 24 hours, or more than 4 units of packed RBCs transfused within few hours or maybe 1 hour, this is massive transfusion. Now, whenever we are doing a massive transfusion, we can understand it can lead to various complications also. For example, if we are talking about an anemic person or an elderly person, wherein the patient is not able to tolerate huge amount of volume suddenly, then the heart can fail. Congestive cardiac failure can occur. So this CCF beta, this is congestive cardiac failure. Congestive cardiac failure. This is due to volume overload. Sometimes after massive transfusion beta, we find hyperkalemia. Hyperkalemia. Now, why there is hyperkalemia? Just imagine beta that blood bag where blood is stored. Now, we know that potassium is intracellular. When in the blood bag, the RBCs, they are continuously getting lysed. They are continuously becoming dead, slowly and slowly, slowly and slowly. And when they are becoming dead, the potassium is leaking out and is getting collected in the bag. When huge amount of transfusion is being done, then huge amount of free potassium may go into the recipient's circulation, which can lead to hyperkalemia. This particular complication, hypocalcemia and hypomagnesemia, is not seen nowadays, but earlier when we were using citrate as the anticoagulant, then the property of the citrate was, when we were giving massive transfusion and we were using CPD blood, CPD anticoagulant, then huge amount of citrate was going into the recipient. And this citrate used to bind with the calcium and magnesium of the recipient. So the level of calcium and magnesium in the recipient's blood used to fall. That is hypocalcemia and hypomagnesemia. But now, since we are not using citrate, so this complication is not seen nowadays. Apart from this beta, if you are giving huge amount of blood, you may not get sufficient time for adequate warming of that blood. अगर बहुत सारा खून जल्दी जल्दी चढ़ाना है ना, तो अपने को इतना वक्त नहीं मिल पाएगा कि हम उसको गर्म कर पाए ठीक से. So we tend to transfuse the cold blood, and this can lead to hypothermia in the recipient. Also beta, thrombocytopenia. In that stored blood, the platelets are also getting lysed. So when we are transfusing massive blood, volume is going inside. But if viable platelets are not there, then looking at the volume and the platelets, there is relatively low concentration of the platelets, and that is what we call as thrombocytopenia. The same thing applies to clotting factors. When massive transfusion is being done, even the clotting factors die very quickly in the stored blood. So you are transfusing the volume, but the viable clotting factors are not there. So volume is going inside, but the viable clotting factors are not much. So if clotting factors go down, then clotting will not occur and blood will keep on leaking from the cut surfaces. This is called as DIC, disseminated intravascular coagulopathy or dilutional coagulopathy. In these cases, we have to give clotting factors like fresh frozen plasma. So fresh frozen plasma is stored at minus 40 degrees centigrade temperature, minus 40 degrees, and this is rich in clotting factors. This is rich in clotting factors. The shelf life is 6 months to 2 years. Earlier, we used to see metabolic alkalosis, but please delete this. Now, it is not alkalosis, but it is metabolic acidosis. And the simple reason is stored blood has a pH of 6.3. You know the blood has a pH of 7.35 to 7.45. Our blood is slightly alkaline, but stored blood pH is 6.3. Massive transfusion of 6.3 will cause metabolic acidosis. 7 is the borderline between acidosis and alkalosis. Earlier, we used to see this metabolic alkalosis, especially when citrate was used. Because what used to happen, if CPD is being used, then this citrate, when it went inside the recipient, it used to get metabolized in the recipient liver into bicarbonate. So huge amount of bicarbonate were formed inside the recipient. And bicarbonate is a base alkali. So huge amount of bicarbonate means huge amount of alkali in the recipient, that is metabolic alkalosis, right? But now, since we are not using citrate, we don't see this metabolic alkalosis. So now we see metabolic acidosis, right, beta? So this is something related to blood transfusion, and I think we are done for today. And here we would just like to take a break from today's session. We'll be solving the queries immediately after this, so you have the option of typing your queries. Just one small thing which I would like to remind you, beta. Just one small thing which I would like to tell you, that why we are here, why we are attending these classes, right? We all have got only one purpose, beta. That is to crack the 17th of December FMG exam. We know what is the path, how the things are going to be, what is going to be the schedule, how the tests are going to be conducted, how we have to learn from these tests on a frequent basis, on a weekly basis, right? Apart from this, very important thing, beta, it is the intensity of study which matters, not the duration of study. Intensity of study means when you're attending these lectures, how focused and how concentrated you are. When you are learning these lessons or revising these lessons after the class, how intense you are. We all know and we all have experienced, beta, that whenever we have to appear for some exam, whenever we have to appear in some test, just before the test, our intensity is very high and we are completely focused, dedicated and concentrated. And the amount of knowledge what we are gaining just before the test, because we are very focused, that is enormous. But once the test or the exam is done, then we get a little relaxed. And then many a times we feel a bit lazy, that, oh my God, okay, what was taught today? Acha, blood transfusion. Then you start reading this blood transfusion at a slow pace, and then sometimes you start feeling sleepy. Sometimes when you're reading blood transfusion, you suddenly realize, acha, when I was in third year in my university, oh, what happened? There was somebody, right? So all those type of thoughts starts coming to your mind, and that actually disturbs your focus, right? Never make a plan that you have to study for these many hours, but always make a plan that you have to study this much, and you have to study in such a way that you will learn these lessons by heart. You will remember these concepts by heart, right? On a daily basis. How we can improve our focus, how we can improve our concentration. For that, I have got one very simple thing, beta. There should be fire in your belly. That fire in your belly, that craving inside you, that yes, you have to do it. Yes, you have to do it. You have to keep pumping yourself. You have to keep pumping yourself that yes, I have to do it. Come what may. I know what I have done in my last 6 years. I know what everybody in my family have done in my last 6 years. I know that when I went outside in a foreign university, I was just at a tender age of 17, 18, 19 or 20. I was not at all mature at that time. But still, I went there. And there, I know in what circumstances I have fought with so many things just to ensure that I complete my graduation. Let me become MBBS. And my dear friends, you know that you would have taken only one meal in 24 hours, and that too in the night. There would have been so many nights also when you might not even have had a meal. Let me remind you, beta, you really have made so many sacrifices in your life. But your parents also have made too many sacrifices for you, which they will never ever show to you. They will never ever let those things come to you. This is what a parent is. You know that how they would have arranged the college fees. You know how they would have arranged your stay expenditure, your books expenditure, and various other expenditures. Agreed that you would have had only one meal in a day. But beta, believe me, there would have been so many days, so many nights when your parents would also have slept just by drinking a glass of water. So it is not you alone in this journey. It is your parents also who are along with you in this journey. If we have made so many sacrifices in our life, if our parents have made so many sacrifices in our life, now beta, the coming 4 months and 20 days, these 4 months and 20 days, let us promise to ourselves, let us commit to ourselves that come what may, I am not going to stop that fire in my belly. I am not going to let that fire slow down. Let me keep that fire burning inside me. Let me keep that fire pump me always to study as hard as possible. We know that it is not a cakewalk, but we also know that it is possible, it is doable, and your seniors have been doing this time and again. So there is nothing which is impossible. It is very much possible. It is very much doable. Let's commit ourselves. Let's promise ourselves that whatever we have done in our life till now, let us just remain dedicated. Let us just remain focused for next 4 months and 20 days, and let us study as hard as possible, as hard as possible. Let us concentrate nicely. Let us learn these lessons nicely. Let us revise the concepts nicely, and then let us see who on this earth has the power to stop us in cracking the 17th of December FMG exam. ध्यान रखिएगा बेटा, जो त्याग और तपस्या आप सब ने की है, उस तपस्या और त्याग में आपके पेरेंट्स भी भागीदार हैं। अगर आपने सिर्फ दिन में एक बार खाना खाया है, बहुत सारे ऐसे भी दिन गए होंगे जब आपने खाना भी नहीं खाया होगा और सिर्फ पानी पी के सोए होंगे। आपके जो माँ बाप हैं उन्होंने भी बहुत त्याग और तपस्या की होगी, तब जाके आपके कॉलेज की फीस जमा की होगी, तब जाके आपकी पढ़ाई के लिए किताबों का इंतजाम किया होगा, तब जाके आपके रहने और खाने पीने का इंतजाम किया होगा। तो हम इस सफर में सिर्फ अकेले नहीं हैं, हमारे वो माँ बाप भी हैं जिन्होंने हमें कभी भनक भी नहीं लगने दी और ना जाने कितने दिन और कितनी रात उन्होंने भी पानी पी के अपनी रातें गुजारी हैं। आपको कभी पता भी नहीं चलेगा। जब हालात ये हैं तो कैसे हम अपने अंदर की आग को शांत रख सकते हैं? जो हमारे अंदर की आग है इस एफएमजी एग्जाम को क्रैक करने की, चाहे कुछ भी हो जाए धरती पे, हमें यह पता है कि 4 महीने और 20 दिन में हमें जो इन क्लासेस में सिखाया जा रहा है, हमें जो इन क्लासेस में नॉलेज देने की कोशिश की जा रही है, जो कॉन्सेप्ट देने की कोशिश की जा रही है, अगर गेम इन्हीं कॉन्सेप्ट और इन्हीं चीजों से उन 240 सवालों की बनने वाली है, तो कैसे हम अपनी उस आग को शांत रखें? कैसे हम कोई भी कदम ऐसा उठाएं जो इन लेसन्स को हमें ठीक से याद करने में या समझने में रोकता होगा? दुनिया की कोई ताकत आपको रोक नहीं सकती। बस अपने मन में अंदर दृढ़ विश्वास रखिएगा, हिम्मत रखिएगा, हौसला रखिएगा। उतार चढ़ाव आते रहते हैं, लेकिन जीतते वो हैं जो इसको शांत रखते हैं और अपने लक्ष्य की तरफ निरंतर बिना डगे बढ़ते रहते हैं। दुनिया आपके कदमों में होगी। बस हिम्मत रखिए, हौसला रखिए, पॉजिटिव रहिए और इन लेसन्स को अच्छी तरह से पढ़ते रहिए। Many thanks for listening so patiently. May God bless you all. Wish you all the very best. May you keep yourself positive and pumped up, and may you come out with flying colors. May every one of you pass with flying colors. Thank you very much. Have a good night. And now I'm open for any questions and answers. I would be very happy to respond to your queries right now. Thank you very much. So first, beta, let me take a look at the chat box, at the chat section, if there's anything, and then I'll take a look at the WhatsApp. Right, so there is nothing as such in the chat section of the app. So let me go to the WhatsApp and let me start answering the queries which were asked to me earlier. Right. So I'm starting from 5:30. The queries which were asked at 5:30 in the evening. Livia from Ama School of Medicine. How to differentiate between pneumothorax and tension pneumothorax in chest X-ray? Because in both of them there is shift in mediastinum. No beta. In pneumothorax Livia, there is no shift of mediastinum. Pneumothorax is just one side lung compression. Tension pneumothorax, there is mediastinal shift along with pressure on the opposite lung. Vijay, thank you, beta. Thank you so much, Vijay, from Bogomolets for such wonderful words of appreciation. Thank you, beta. God bless you. Thank you, Navyu. Thank you, Aditya. Ashok from Orenburg, beta. Is it always necessary to give analgesic before performing breathing exercise? Generally, beta, in chest trauma, we have to give adequate analgesia. Otherwise, because of that pain, the patient is not comfortable in breathing exercise. Yeah. I just mentioned about the analgesia in the flail chest topic, beta, but this analgesia is actually very important in any kind of chest trauma. The last 5 digits 91877. Beta, please do mention your name and university. Is there any kind of anesthesia needed for puncture-like procedures? Yes, if the patient is very apprehensive, we can use some local anesthetic spray. Thank you, Akash. Thank you so much, beta. Dimahi from Our Lady of Fatima. Can you explain the tension pneumothorax and open pneumothorax with example, beta? See, if there is an open pneumothorax, Dimahi, there would be a penetrating wound in the chest. Now, massive air is going inside. So, massive air collection is taking place inside. This is a case of open pneumothorax. And this massive air collection is going to put pressure on the same side lung. So, the same side lung is going to collapse. This is going to put pressure on the mediastinum. So, the mediastinum will be shifted to the opposite side. This is also going to put pressure on the opposite lung. So, the opposite lung will also be compressed and patient will have respiratory distress. This is tension pneumothorax, which is seen in open pneumothorax as well. But at the same time, if there is no penetrating wound, if there is no open wound in the chest, sometimes what can happen, if the patient is having, say, emphysema and there are emphysematous bullas, they can rupture and huge amount of air can leak into the pleural cavity. This huge amount of air in the pleural cavity can put pressure on the ipsilateral lung, mediastinal shift and the opposite lung, leading to tension pneumothorax. So, tension pneumothorax can be seen in open pneumothorax as well as in closed pneumothorax. I hope this helps, Dimahi. Krishna, I would like to know your university, beta. Your question, what are steps taking the intercostal tube, because it might also lead to open pneumothorax if not done properly. Yeah, we have to be very careful, beta, so that outside air does not go inside. So we use the finger dissection so that we are creating minimal hole, and since the intercostal muscles are there, the catheter which is going is through the muscles. So those muscles are able to stop the leakage or stop the inflow of outside air to inside. In removing the intercostal tube, beta, again, yes, we have to be very careful, because as soon as you remove the tube, there is sudden gush of air, what you can see. So we have to have that sealed dressing ready. As soon as the tube is taken out, we just seal that wound immediately. One more doubt about, we can also make the IAP to IPP to save the person in pneumothorax. Please, I am not able to get this, beta. If there is liquid in the lung, what it is called is Samrat from Kiev, beta. This is pleural effusion, beta, because like in diseases say tuberculosis, we find that liquid collection in the pleural cavity. That is just a simple pleural effusion. Yes, beta, Samrat, you can share that video, whatever you want to share, please. Unnati from Orenburg, beta. I didn't understood what is paradoxical breathing. Can you please repeat? Yes, Unnati. Paradoxical simply means the opposite movements of the ribs. Normally, what happens, Unnati? When you are breathing in, the lungs move out, ribs move out. Paradoxical means during inspiration, lungs move out, ribs go inside. So in flail chest, the flail segment of the fractured rib, that shows paradoxical movement. During inspiration, when the lungs are going out, the broken rib segment is going inside, so the chances of lung injury are very high. I hope, Unnati, this helps. The last 5 digits 91953, beta, please mention your name and university. Is it possible to add 1.5 to 2x feature in iOS devices as a beta? We have tried it number of times earlier, but this is not possible from the Apple side. So it is not possible to go at 1.5 or 2x feature in iOS devices. Firdosh from Uzgarod. Dull sound, beta. Dull sound will be heard whenever there is any liquid collection, any fluid like pleural effusion or maybe hemothorax where there is blood. So because of that blood around the lungs, you will not be able to hear that lung air tympanic note. So that sound will be dull. Just a second. Hinal from Grodno, beta. In case of extradural hematoma, the blood is getting collected outside the dura mater beneath the periosteum or the pericranium. So it should be somewhere between the out table and the dura mater. प्रिया फ्रॉम वोल्गोग्राद, बेटा 14 गेज एडल्ट एंड पीडियाट्रिक दोनों में यूज करेंगे क्या? नो बेटा, 14 गेज 14 गेज you are asking for which thing? If you are asking for needle thoracocentesis, yes, we use the widest bore needle available in the emergency. Though if it is a child, we avoid using a 14 gauge, we prefer using a 18 gauge in a small baby. The last 5 digits, beta 3007 from Uzgarod. Please do mention your name, beta. Doc, what if there is injury with gunshot instead of knife? I couldn't get your question, beta. Please do mention in what reference you are asking about gunshot injury. Though it is going to be the same if you are asking about the chest trauma. Vidya from Central America Health University, beta. Pneumothorax and hemothorax. Pneumo basically is air collection in the pleural cavity and hemo is blood collection in the pleural cavity. The last 5 digits 04123, beta, please do mention your name and university. I think I have not saved you in my contacts. Is there any chance of hypoxia occurring due to the injury? There is a chance of hypoxia in any injury, beta. Even if it's a head injury, there is a chance of hypoxia. Sunisha from Hebei. How long we have to keep ICTD after draining the air? It depends on what is the collection coming out in the ICTD. Sometimes maybe 2 days, 3 days, sometimes even 5 days. Once all the collection has been drained and once adequate lung expansion has taken place, then we try to remove the ICTD. Generally, what happens, the question is there any chance that pneumothorax can happen again if the fracture is not healed? Yes, beta, there is a chance. If there is overriding of the ribs, there is a risk that pneumothorax can occur again. But generally, within a few hours itself or within 24 hours itself, the ribs become immobilized as the healing starts, callus starts forming immediately after injury. Jay from Davao Medical School Foundation. If we can't find any foil for valvular dressing, can we put pressure with the hand at sucking wound? Yes, we can put the pressure with hand at the sucking wound, no issues. But then whatever has gone inside will remain inside and will not come out. Rohit from Karazin. In the neck trauma, which zone is considered the most dangerous or sensitive area? Usually the zone 2. Jagadish from Davao Medical School Foundation. During percussion, you mentioned the movement occur at elbow. No, beta, it is not the elbow. That was my mistake. The movement in percussion occurs at the wrist joint. Whiplash is something related to beta seat belt abdominal trauma. The last 5 digits 68624. Please do mention your name and university, beta. Prithvi from Usgarod. Exact difference between pneumothorax and tension pneumothorax. Because as you said, open pneumothorax leads to tension. That means both pneumo and tension pneumothorax caused by injury. Can you give one example for both? But I think you are getting confused between open pneumothorax and simple pneumothorax, right? Suppose I say there is a rib fracture only, there is no external wound. Now, because of the rib fracture, there is injury to the pleura or the lungs by the fractured rib. So, air starts leaking into the pleural cavity. If only a small air leak is taking place, this air will be confined at one place only or on one side only, and this air would be putting pressure on one-sided lung only. This is a pneumothorax, right? Now, open pneumothorax is a emergency situation where there is a open wound because of which the outside air is going inside under pressure. So that causes massive air collection inside, which not only put pressure on one-sided lung, but also put pressure on the mediastinum, leading to mediastinal shift, and then putting the pressure on the opposite lung. So this is what is tension pneumothorax. Simple pneumothorax, no open wound, just a rib fracture, creating a collection of air in the pleural cavity. Open pneumothorax, open wound in the chest, penetrating trauma in the chest, outside air getting sucked inside. Because of this outside air getting sucked inside, it can lead to tension pneumothorax. Bhargav Patelia from Crimea. As we are doing whiteboard needle thoracocentesis in tension pneumothorax, and as there is pressure difference between lung and atmosphere, so should we add something to needle like we had open end of tube in tube thoracocentesis? No, beta. In tension pneumothorax, patient is dying, and that is because there is huge amount of air and a huge pressure inside the thoracic cavity. So in tension pneumothorax, if you are putting a needle, the inside air will come outside only. And once we are able to decompress the lungs, maybe within 2 minutes, 3 minutes, 5 minutes or 10 minutes, then we are actually putting a tube into the pleural cavity, that is intercostal tube drainage, and then we remove the needle. Rehan from Orenburg, Beta. My query: in which position inside transport the patient should take the hospital to ensure minimum blood loss if there is severe internal bleeding after the abdominal trauma? Generally, we transport the patient in the supine position. Akshay from Smolens. First aid for cardiac tamponade. It is pericardiocentesis. Yes, it is a syringe. It is a needle by which we are removing the fluid or blood. It is a site of incision for retroperitoneal trauma in zone 1. It is a midline laparotomy, beta. Priyanka from Karasina. What is sucking wound? Basically, if there is any penetrating trauma, somebody has hit a knife in the chest. Now, the outside air is continuously getting sucked inside because there is an open wound and the outside pressure is positive, inside pressure is negative. Next question: if patient is stable, then what we'll do in zone 2, zone 3? Just a conservative treatment, beta. Generally, nothing is required and the injuries, they heal spontaneously. The last 5 digits, beta, 16664. Please do mention your name and university. From Tajik, yeah, table is given for adults. In case of children, beta, depending on the age, you can just increase that. For example, the table is for adults class 1, less than 100 is class 1 in adults. But if you are talking about a school going child, then less than 120 is class 1. In a preschool, less than 140 is class 1. And in an infant, less than 160 is class 1. A.V. Patel from Grodno, beta. What is the meaning of blood clot in a clenched fist? If you are doing the surgery heavy, then what can happen? There would be bleeding in the peritoneal cavity, and when you are removing those that bleed, that actually has formed clot. So when you remove that clot from the abdomen inside or from the peritoneal cavity, if you just collect those clots in a fist means mutti, right? If you collect those clots in a fist, that is equivalent to 500 ml. Pallavi, may I know your university, beta? Your questions are: at what level should we insert the needle for pericardiocentesis? It is through the Xiphi sternum, Pallavi. What are the structure that can be damaged while placing an intercostal tube drainage? There may be injury to the intercostal nerves. We might also cause injury to the lungs. How does positive pressure ventilation work? If suppose you have put an endotracheal tube and you are giving positive pressure through that tube, then this positive pressure will help in keeping the flail segment away from the lung. Surgical intervention for flail chest is to remove or attach the broken rib piece. Remove the broken rib piece. Divyansh from Orenburg, beta. Major difference between closed open. I think I have repeated this multiple times, beta. Please see this video. Anindita from Kiev, beta. Very good evening to you. After IV fluid, blood, etc., within how much time we have to look for improvement and decide about surgical exploration? It all depends on the situation, beta. It all depends on how the patient is responding. We might have to take the patient for laparotomy within 5 minutes. We can even wait for half an hour to 1 hour. Yeah, urine output monitoring is done simultaneously, beta. As soon as the patient has come in, urinary catheter is put in the patient. Anirudhan from XJT University. Good evening, sir. Very good evening, beta. A patient with unstable hemodynamics arrived in the ER and the in-charge doctor suspects retroperitoneal bleeding in zone 1 and decision to shift to OT for surgery. While doing the incision, the patient goes into cardiac arrest. What should be the next best step? Cardiopulmonary resuscitation. CPR would be the next step, beta. As soon as the patient has gone into cardiac arrest, we have to do the CPR. Also, sir, could you explain how the retroperitoneal assist, like using ultrasounds? Yeah, we can assess the retroperitoneal space using the ultrasound if the patient is unstable. But if the patient is stable, we can go ahead with doing a CECT. Pooja, may I know your university, beta? You want to ask something about gunshot injuries? Gunshot injuries, beta, just like what we talked in penetrating trauma. The only thing what we need to remember here is in gunshot wounds, these are dirty wounds, so we cannot do a primary suturing, whether it is outside on the abdomen or it is somewhere inside. We cannot close them, so we just leave them open and leave a tube drain near to that injury. Raj from Bogomolets. I hope if you watch this video, beta, I have explained the blood clot in a clenched fist again, right? The last 5 digits 93369, beta. Maybe I have not saved you in my contacts till now. After patient donating a pack of blood, if we find that he's HIV or any other infection, what we'll do with that pack? Will we sterile the blood or discard? We usually discard that blood, beta. The last 5 digits 97222. Please do mention your name and university, beta. I have a question that usually I read mostly theory. Sometimes I'll forget the disease, clinical symptoms. What is the best mark the answer correctly, subconsciously correct? That means am I lagging in concept? Whenever I heard the disease name, I don't remember the path physio behind it. Still mark the correct answer, sir. How can I improve? Beta, I think you need to understand the disease properly. You need to understand why that disease is occurring, how and why the patient is presenting with those symptoms, and why we are doing this type of management. If you are able to make the concept nicely, then you will be more confident in answering these questions better. Bukovinian Thakur, why we don't do thoracocentesis in adults or mid-clavicular line? Because beta mid-clavicular line, there is a lung behind that. So there is a risk of lung injury if we are putting a needle or a tube in the mid-clavicular line. Which component we put for anticoagulant in FFP and platelets? Generally, we use the same Sagam. Beta last 5 digits, last 5 digits 27820. Beta, please do mention your name as well. You are from Ushgrowth. Applying whiteboard needle and it is open from one side, no water bag, so air will not go in lungs. No. If there is huge pressure inside, then the air will be moving from inside to outside. Intention. Okay. Shubpreet, please do mention your university. Whiplash injury on the neck. Beta, yes, there is a risk of injury to important structures in the neck. The cervical spine fractures. Yeah, I think this whiplash is discussed in detail in forensic medicine, so I do not want to confuse you at this point of time. Nitesh from Orenburg, beta, investigation for pneumothorax. First investigation is chest x-ray, best investigation is CT scan. Shinu from KNMU, how to differentiate between pleurisy, pleural effusion and hemothorax in chest x-ray. There is difficulty in differentiating hemothorax from pleural effusion because both are liquid collection, and in both the cases there is white haziness and blunting of costophrenic angle seen commonly. However, pleurisy, we don't find that classical fluid collection at the basis. Rather, we see fibrotic changes towards the costophrenic angle. Hypothermia is the commonest complication after massive blood transfusion. For any trauma situation, beta, the investigation of choice would be CT scan. Beta, last 5 digits 22022. Please do mention your name and university. You have 2 queries. One, we get a declaration form to fill before donating blood. Is the blood tested irrespective of what we fill in the form? Yes, the blood is tested irrespective of whatever you fill. Number 2, mannitol is a very strong osmotic diuretic. We are told that it's used to treat severe cases of increased ICP glaucoma. Why do we add it for the blood storage? Mannitol basically, it is also used to provide some energy source so that the viability of the RBCs, they can increase. RBCs can remain viable for a long period of time. Mahesh from Orenburg, thank you very much, beta. In thoracocentesis, how long or how often we need to change the needle? Beta, thoracocentesis, if you are doing needle thoracocentesis, na, in tension pneumothorax, it is just for a matter of few minutes, that's it. And then we have to put the intercostal tube. Now, tube thoracocentesis, that is intercostal tube, that remains inside till the time you feel that now the collection has been removed from inside and the lungs are expanding nicely. Abhijit from Davao, in some questions sometimes values differ, like pulse around 135, class 3, class 2, basically what I have given the values, beta, they are according to the ATLS guidelines, that is Advanced Trauma Life Support Guidelines. There are variations in different textbooks, but let us follow one resource where we feel that your National Board of Examiners are following that resource and what is commonly being used as guidelines in the hospital practice. Tarun from Orenburg, beta, septic shock is simply related to infections. Whenever there is infection somewhere in the body, then because of that infection there is inflammation, and in inflammation we know acute inflammation there is vasodilatation. So there is migration of blood towards that infected organ or the infected area. If there is migration of blood towards the infected area, then definitely the other organs, their blood is diverted. So their oxygen supply is diverted. So the other organs are facing deficiency of oxygen. Deepak from Kathmandu, is it any side preferred, right or left in thoracocentesis? Deepak, it depends on which side the collection is. If it is the right pneumothorax, you will put on the right side. If it is left, you will put on the left side. Donald Watts from Orenburg, do we have a surgical treatment? Yes, we have a surgical treatment for flail chest. We have to remove those ribs which are actually creating the issues. I hope from Northern State, please do mention your name, beta. You have asked for explanation of tension, pneumothorax, cardiac tamponade and sucking wound. I think if you listen to this query session in the video, what is going on right now, you will be getting all your queries solved. Triangle of safety is the area where the lower border is actually at the nipple line in the fifth intercostal space, or you can say the fifth rib, and upwards it is going towards the axilla. Pratik from Taver, dilated neck veins, beta. If there is anything which is causing compression of the superior vena cava, that means blood from the head and neck and the upper limbs, which is ultimately draining into the superior vena cava. If somebody has pressed that superior vena cava, then this blood will not be able to flow into the superior vena cava. So there will be pooling of blood in the neck and the facial veins. And that is how the neck veins will be dilated. Last 5 digits, 74664. Please do mention your name and university, beta. In case of left kidney damage or anything which cause hemorrhage, how the blood will collect in splenorenal pouch, which is in superior side of the kidney. Actually, when the blood drains towards the inferior side, just imagine that patient is lying supine, and then what is going to happen, beta? If the patient is standing, then you are right that it will be draining towards the pelvic area. We can use the Timan from Uzgrowth, the EDT as well. Ashutosh from Northern State. Thank you, beta. Thank you for your kind words of appreciation. Can you please explain what is associated with engorged intention pneumothorax? Beta, intention pneumothorax, if somebody is putting pressure on the superior vena cava, then the blood will not be draining nicely into the superior vena cava. So there will be pooling of blood in the neck veins and the facial veins. So the neck veins are getting engorged and dilated. Deepak from Orenburg, if someone penetrate knife multiple times in the abdomen on the road and he took knife with him and the patient is not stable, what to do at this time? Patient is lying on the road collapsed. You have to immediately take the patient to the hospital. It is Gurjeet from KNMU. Volume overload is not only seen in anemics and elderly, but yes, there are more chances of volume overload in anemics and elderly. Arco from Southwest Medical University. Surgery has been a fearful subject, but this time under teaching and my hard work. Thank you, beta. Thank you. Thank you so very much for your kind words of appreciation. May God bless you, beta. Vatsal Joshi from Growth No Beta. How can we know whether the intestine is penetrated or not in the abdominal trauma? Definitely, beta. If suppose the patient is stable, then we just keep the patient under observation for 24 to 48 hours. If there is any intestinal perforation, the intestinal contents will leak into the peritoneal cavity, which can cause peritonitis maybe in few hours, and then patient will present with diffuse abdominal pain, nausea, vomiting. When we examine these patients, there will be evidence of peritonitis like diffuse tenderness all over the abdomen, diffuse guarding and rigidity of the abdominal wall. Then we can take the X-ray and we'll see free air under the diaphragm on X-ray. Samrat from Kiev. Yes, beta, I saw this video. This is actually a case of tubercular pleural effusion. And the needle is being put in the 8th intercostal space, I guess, in the posterior axillary line. And the pleural tapping is being done in these cases. So this is a needle thoracocentesis, what we are doing for draining the pleural effusion. Arif from SUNY. Thank you, beta. Thank you very much. You want to differentiate between coup and counter coup, Arif. If there is, suppose, injury on the frontal side or maybe the forehead, and if suppose the frontal part of the brain suffers from injury, that is injury at the site of impact, which we call as coup. Sometimes what happens, beta, if there is a blow on the forehead, this impact will cause shaking of the brain inside the cranium, and because of this shaking of the brain inside the cranium, the posterior part of the brain, that is occiput, will be hitting the occipital bone, and so occipital part of the brain suffering from injury. This is injury remote from the site of impact. Impact was at forehead, but injury is in the occipital part of brain, that is remote from the site of impact. This is counter coup. Rajat from SEMI, how to fix symphysis menti? The symphysis, we can do it with the help of plate and screws, beta. Without cut surface, beta, that means if the generally the example what we have shared, that we see generalized oozing from the wound, that is when the patient is undergoing some surgery, so definitely something would have been cut inside. Then we are seeing that generalized oozing. Otherwise, in an unconscious patient, beta, we might find that tachycardia and the urine output would be going down. Thank you so very much, Ankush. May God bless you, beta. Jai from Privoloshi Research Medical University. The X-ray of hemothorax. If you are seeing any white haziness at the bottom with blunting of the costophrenic angle, That is what is hemothorax. Mahesh from Ama. Sagam blood in blood transfusion, beta, that is the anticoagulant. That is S for sodium chloride, A for adenine, G for glucose, M for mannitol. Also, doc, in ICTD, if the fluid drained out completely if unnoticed, will air enter via the tube? No, 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 no. The air will not enter because the outer end of the tube is dipped into the water column. But if suppose you raise that bag, which is at a lower level than the chest, if by chance you raise that bag high up, then yes, there is a risk of fluid or air going inside. Hyperglycemia, Chirag from Orenburg probably, or GMU. Hyperglycemia in head trauma, beta, that promote the chances of infections inside the brain. Plus hyperglycemia that can create a osmotic pressure and can increase the bleed as well. Hemopneumothorax, beta, that is simply collection of both air and blood in the pleural cavity. Ali from Karasin, 1 gram hemoglobin is 1 unit 450. 1 unit of blood is 1 pint, right, which is 473. Yeah, 450 is the standard according to the US data which we take. Clerical error simply means that it is not a scientific error. It is just by a human mistake. The mismatching is done. Mohana from Yangzhou, beta. If the patient is stable and there is an open wound, you can do a CT scan. Definitely yes. Shelf life of platelets. Shelf life of platelets is somewhere around 3 to 5 days. Ragul from Venezia, beta. Basically, for seat belt injury, if you look at the site of the seat belt, right, that seat belt is passing through the abdomen close to the duodenojejunal flexure. So, whenever there is a high impact, because the abdomen is binded by the belt, the points where the mesentery is attached, like the DJ flexure or maybe the ileocecal region area, these are the points where the mesentery tends to get avulsed, and this may cause injury to the blood vessel supplying blood to the intestine. I hope, Bharul, you from Jalen, you would have heard the explanation of septic shock. If not, beta, please do watch the query session in this video and you can get that. Ayan from Orenburg, can you please share MCQ related to topics we discussed? Ayan, better just look at the workbook questions so that you can get an idea that how the questions are framed from these different topics. Akshay from Raizan. Occasionally, tension pneumothorax may occur without mediastinal shift if malignant disease or scarring has splintered the mediastinum. See, if there is scarring of the mediastinum, or if there is damage to the mediastinum, or if in malignant disease the cancer is actually fixed to the trachea and the other structures, then definitely the mediastinal shift may not be seen, but the pressure may be so high that it will start pressing on the opposite lung. So tension pneumothorax simply means when both the lungs are under pressure, because of which there is hardly any oxygen going into the blood. Abhiti from Davao, yes, we can do a CT scan, but many a times if the amount of leak coming out from the intestine is very less, we may not be able to see anything on CT scan, and then we may get a false impression that there is no injury. We might discharge the patient can come back to us again, maybe after a few hours with signs symptoms of peritonitis. Thank you very much, Peter. Thank you for your patience. God bless you all. Wish you all the best. Bye-bye. Take care.